We are finishing chapter 14 today. I'm going to get through 15 and hopefully 16. We'll see. All right, we're live, so don't talk bad about anybody. While I'm doing this, so when I left here Thursday night, I was cruising down the road, and a deer came out onto the road, and I hit it on my motorcycle. Yep. I know, right?
So you're not injured.
Nope. I actually was able to pretty much save it all. Only thing that came out of it was I had a sore leg. I couldn't walk on it that night. And then the next day, at first I wasn't able to walk. By the day I got started, I was fine. Just still get sore. But it came up on the road, and I saw it, and so I hit my brakes, started to slide sideways. I saw the deer was going to go back off the road, so I left the brakes and then towards the backside. As I did that, the deer decided he was going to go the other way across the road. Son of a bitch. And so I throttled down, because at this point all I could do was try to get around it. So I throttled down, it decided it was going to run, and when it ran, it hit me right in the leg, and stayed in the throttle. And as it hit me, it kind of spun a little bit. It hit my back shock tower, knocked into my bike a little bit, and whatever it did, I don't know. So I didn't even watch. But I just kept on, and so I got home. I just had a few deer hairs in my shock tower and a sore leg. I was like, oh, got that one relatively unscathed. Nope. No, I did not. At one point in the whole thing, whenever I was sliding sideways, I was thinking, I had to just go ahead and let this go ahead and go on down. So it was already sideways, it was already in a good position. The bike was already turning where it was in a low side, and I would have just rode behind the bike, which obviously the bike's heavier, so it would go faster. And it would have been fine. Maybe some road rash on my legs, but for the most part, it would have been fine. They're like, nope. Yeah. It was quite scary. So anyway, with the whole thing, I think I feel like the whole reason for that close of an encounter with it is because I have a tinted shield on it. Well, I usually wear my tinted shield up at night, and I have goggles underneath my helmet, and so I just wear goggles at night. Well, whatever it was, I don't know if it was wind direction or what, but that tinted shield didn't want to stay down, and it kept wanting to flip down, and the wind was coming in and making my eyes water. So I've ridden and I would tinted shield down before, and it really, you see okay, but not super good. And I kind of blame that, having that tinted shield. I'd let the tinted shield go ahead and go down. So I didn't really see it until, I was going faster than my brakes getting stopped. I have a LED light on that motorcycle, so I could see pretty far. I could see probably where if I were to hit something, it would be a very low speed impact. But with that tinted shield, I can't really see how it goes.
They said she done the same thing. She wanted to go this way, wanted to go that way, and she was not even gonna do it.
Yeah. Well, that's what she would have done to me if I was been in a car, hitting right at the door. She was free and clear. She had a clear path. I don't know if you know, if you ever watch a rabbit in between your headlights, it darts back and forth. So I don't know if they see the edge of that light and movement, and so they don't know what the heck to do. Maybe if I just put my light off, close my eyes, and yeah. Hello. You gonna learn how to be EMT today? Yeah. Look out, Ellen will try to get her into school. Are you getting dirty looks? All right, we'll go ahead and get started. Zoom this in a little bit. Kind of. Is this where we already tell physical exam? Oh, we're even further than this. One 103. I just left over there. There we go. 116. Reassessment. Teaching time 20 minutes. All right. So the reassessment. As you guys have already kind of heard, the reassessment is something that is ongoing throughout the whole process. It's so you can make sure that either your treatments are helping the patient or that the patient isn't getting worse, that you could re-gear, refocus if the patient's getting worse, or if they're getting better, you know, hey, I'm on the right track. And sometimes, no matter what you do, the patient's are going to go downhill. And so during reassessment, I mean, if this is happening, all you can do is drive faster. Keep thinking, is my airway secure? Is my breathing secure? Do I have circulation? Did I stop all major bleeding? Have I done everything I can to this patient? Is there other things I could do? Let's use a trauma patient, for instance. Let's say that you're going through that, and maybe, you know, keep going through that. Maybe you don't have them covered up, and they're in shock. You know, throughout your reassessments, they're not getting worse. You know, you keep working through it. What do I need to do for this patient? Oh, hey, you know what? I can't really do much else, but I'm not preserving body heat. So maybe kick on that heater, throw a blanket on them, or whatever. So, you know, discover or figure out that there are, you know, a few other things you can do. As a basic, you know, you guys are able to do a lot more now than you were even 10 years ago. But as a basic, your job is to get a patient to the hospital. You guys do very little stabilizing. Paramedics, we have a plethora of medications and different tools at our disposal that we could stabilize patients to the best of some patients' ability. Now, sometimes they need blood or something before they go on, so we'll have to stop here, or Air-Evac, not very good. But for you guys need to determine, is there, in your very limited toolbox, there's something you can do to help them out. If there's not, and they're a critical patient, your only option is to call ALS or stop at a local, you know, your local hospital, and let them kind of secure your patient. So one thing that I think my people have, and this is kind of off the class, the problem that my people have is understanding that, for the most part, Roger Mills can offer all the same treatments as Elk City. Or they're doing the same thing. They're a triaging hospital, basically. You get a patient in, and they recognize, hey, we can't do anything for this patient. They get them stabilized to go to a higher level of care. So, like if it's a trauma patient, bad trauma patient, OU. But they are higher than what you are on the ambulance, and they could do more things than you can as a basic on that ambulance to prepare that patient, give them the best chance to make it to the hospital. So utilize them. Don't bypass Roger Mills just to go to Elk City. We have had instances in the past where staff have told us to go on, and Ellen has addressed that. So if that happened, you got to let us know so we could take care of it. It's not something that I want my crews. I'm saying this to you guys, but most of you are work for me. It's not something I want you guys to address. It's don't try to address it over the radio. Don't try to show up at the ER doors and force the issue unless it's patients. I mean, you have to secure their way. But let me know. I talk to Ellen, and Ellen and I have a good working relationship. And most anything that happens like that, we get solved. I say don't address it yourself because a lot of times it just creates a fight and a tension between the staff. So, anyway, back on reassessment. Continues on initial steps of assessment, identifies changes and trends, must never be skipped except for when life-saving interventions prevent you from doing it. So if you're doing CPR and bagging this patient, do you need to do a reassessment? No, you're hands-on and you're constantly, you're in a constant mode of reassessment. But you just can't get past that ABC step, right? Identifies changes, subtle and profound. You know, some changes happen real slow. We talk about, with your initial stages of shock. So you have your complicated shock. You might have a heart rate that's, 102, 104. Blood pressure's still pretty stable. They're a little anxious. Nothing real big. Next time you check them, now the heart rate's 110, 112. Blood pressure might be coming down a little bit, and they're very anxious now. It subtly changes over time like that. It's not just an instant for most of your patients change. Now your profound changes in this same scenario would be you show up, they're talking to you, next thing you know they're unresponsive, and that does happen too. That would be a profound change. We went from talking to me to dead. So, I've already talked to you guys about trends. Your reassessment should expose trends that are happening. Sometimes the trends are hard to even recognize until you're done and you're charting and you're like, oh, hey, look, the blood pressure is trending down, heart rate's trending up. And sometimes it's just hard to see because in the thick of it, it's just a few points. It's not something that, and not until your pressure gets down about 10 points or so do you start going, wait a minute. And so, and then, like I said, sometimes you deliver them where it's only down 10 points and you start looking at it, you're like, oh, wow, okay. Each time our pressure is going down, each time our heart rate's coming up. So, deterioration, you can see the patient deteriorate. Your biggest cue is going to be in their mental status. So the patient at first is anxious talking to you. Next thing you know, they start to get a little lethargic. They're really not responding all that well. That's going to be a big key for you guys. It's like, oh, the things are getting bad fast. We like to call it circling the drain, FTD, like FTD floors, sitting flowers to the fixing to die. Got all kinds of things, a sick sense of humor, but those patients are the ones that you see it happening. You see kind of the look in their eye and things are getting bad. So where you can see improvement, like us, or you guys put them on CPAP, and they're struggling to breathe, not able to talk in complete sentences at all, to hard for them to talk to that CPAP, but they're able for you to hear them. You get that whooshing noise of the CPAP. You have this mask over them, so they're woo, 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 but they're able to talk in complete sentences. You can tell that, and so you could then document that improvement. Communicate with the patient, explain process, and then consider patient's feelings such as anxiety and embarrassment. I think I've hit this quite often. Typically, I use that teenage girl, teenage boy that really they have this, and even don't think just because they're teenagers they're the only ones that have this the pride, the embarrassment. Get the word I'm looking for. Modesty. Thank you. They're not the only ones with modesty. One of Vera, and she's 70, her biggest fear is that she's going to get into an accident and we're going to have to cut her clothes off. And here she is. And so, just, remember that whenever, sometimes we get, you guys, one thing I like about rural medics There's a lot of things I don't like about rural medics, but there's a few things that I do like about rural medics, and it's that you guys never lose that compassion, that empathy for your patient. And I watch a lot of my medics, and they might not be the best medics in the world. We try. We don't run the call volume to really get that comfort level. But one thing that they do very well is they care. In your career medics, we start out caring, but we stop looking at you as a person at a certain point and looking at you as just another body. And so we go into a mode where we're working hard, we're cutting clothes off or whatever, and we stop thinking about the modesty side of it, the human side of the call. It took me coming back to rural EMS, and even took me a little time after that to get back to that. This, just because it's not, you don't see it as a bad call, doesn't mean it's not their worst day. And so it took me a little while, but I've gotten back to where maybe I don't, I'm in my mind, I'm like, yeah, whatever. I always try to show sympathy or empathy for my patient. I try to, reassure and talk with them. And so that is one thing I do like about rural medics. You guys never really lose that. You don't have the call volume to lose that. No, it's not. I promise. Go to IMSA and watch them. You'll just see a completely different way of working EMS than you do rural EMS. It is, and even with flying out here, you're just a body for us. We're just doing our job, and we're efficient at it, but we lose a lot of that caring side of it. And I worked with a nurse at AirEvac, and some would have considered her a bad nurse. And her name is Kelly McCallie. I don't know if anybody knows or not. She's actually from this area. I thought she was a great nurse. She wasn't the strongest nurse on some of the clinical side, but nurses have a different skill set than we do as paramedics. And I never seen her as a bad nurse. But one thing she did awesome was Kelly had an awesome bedside manner. Always talking, and that for me that complimented me very well. I'm not gonna say I don't have the strongest skill set, but I have a skill. My paramedic skills are. They're good enough to get flight jobs, so take that for what it's worth. But she complimented me very well because I had a hard time with that compassion. That hey, I'm Rob. I'm here to take care of you. We're going to take you to the city. Well, and Kelly was awesome at that, so she complimented me very well. So anyway, explain the process. Always tell your medic. Always tell your patients what you're doing and why you're doing it. Hey, we're going to do this 12 week. We want to just be make sure that you don't have a cardiac event going on. And so we're going to go ahead and do this and explain to them. Talking to your patients sometimes proximities, it helps you think about what's going on. Come on. Repeat the primary assessment. Recheck for life-threatening problems, reassess mental status, maintain open airway, monitor breathing for rate and quality, reassess pulse for rate and quality, monitor skin color and temperature, reestablish patient quality. You guys will get that call where your mind goes cloudy. You're like, oh crap, what do I do? There's blood everywhere. This person's screaming. What do I do? Go back to this and just continue to walk through it. Did I do my ABC? Okay, yes. Everything's intact. Maintain an open airway. I monitor breathing for rate quality, and just keep going over that, and that'll help you get through the call. And that's what I don't like about Western Oklahoma or rural medics is sometimes whenever they get that brain freeze, they freeze. And I don't know if it's just because they're with me and they want me to take over the call for them, or if it's that's how they are on a call without me. And
I've had people, I go with them for something and they just take 3 steps back and look at me.
Yeah.
I'm not here to do your job, because I don't even know what, you know.
Yeah, no, exactly. And it always makes me wonder, is this how you handle a call? Because if you, I don't think they do either. Now, the one that I ran with, I think that's what she did because she just threw up her hands and was like, Rob, I don't know what to do. And so I'm like, think about this. Hey, is our airway intact? Well, yeah. Are we breathing? Yeah. All right, we're good there, right? Do we have a pulse? Yeah. Okay. You know, and she was an intermediate. Do we have IVs established? Well, yeah. Okay. You know, and just go through it. We check our vitals. We have her, we're keeping her warm. And so I said, this is it. This is what our job is. We're not expected to come up with a diagnosis. We're not expected to know exactly what's going on with this patient. And I think this one was a trauma patient. We're not expected to know that she has a lacerated liver or a lacerated spleen or whatever. It's not what we're here. We're here to continue to reassess. So we could tell the ER, hey, when we first got on scene, she had a blood pressure 120 over 80. Now it's 80 over 40. And so that they have a picture that this patient is in critical condition. And that's all we do. We try to deliver them alive. And if you get to that point where you could just knock the dust out or smoke because you're gonna freeze up, and just get back to that reassessment, that air breathing circulation, and warm, and I have oxygen going. Okay, go back through it, and keep doing that. You might find something that you missed, blanket, or you might just say, "This is all I can do at this point." Yes, keep looking, keep examining your patient, look for things like that. But sometimes it's all you can do. Yeah. 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 Well, that's good. Yeah, no, that's good. Pediatric note. The mental status of an unresponsive child or infant can be checked by shouting verbal stimulus or flicking the feet, painful stimulus. Okay. Crying is an expected response from a child with adequate mental status, right? And, maybe not her age, but you get down to where they're scared and they're crying. They're not really wanting to talk to you at all. That's normal. Being scared of you. She may, depending on what kind of injuries she has. And so that's a good thing if they're in that state. We could deal with that. But what we don't like dealing with is when you can't stimulate them at all. Reassess and record vital signs. Compare results with baseline measurements. Reevaluate oxygen saturation and document findings to report it. And identify trends. One thing I wish that EMS monitors did a little better is to show you trends. Kind of maybe have just a little bitty bar graph over to the side on that monitor, give just a little space where I can see a direction of whatever it is. Just have like heart rate, blood pressure, respiratory rate, and just have an arrow. Is the blood pressure going down? Is the heart rate coming up? Is the respiration coming up? And if you could just see a little trend, sometimes that would help you out a lot. Or if they're all just flat, that's cool too. So think about it. Think of an example of a problem that might develop into a life threat to the patient on the way to the hospital. One of the best that I could, and I keep going back to this for the EMT, one that you guys really could recognize, treat is your CHF patients. They could go from mild shortness of breath to profound shortness of breath very quickly if left untreated. So you get to that person, they're like, I don't know, I just can't catch my breath, lay down. It's hard to breathe. That should be the first two right there. If they lay down and it becomes harder to breathe, well, they got some fluid in them. But, and that's the one that you guys really could not only recognize, but then come and treat. Now, obviously, if it's a trauma patient, you recognize that FTD, get ALS or stop at a local hospital. So, components of reassessment: repeat patient parts of the history and physical exam. Chief complaint may change, especially with regard to severity. Uh, a lot of times, the most serious injuries are masked by either a more painful injury or a more grotesque injury. Um, you may be concentrating on that femur that is sticking out of their leg, or worse, whenever they get their feet caught in the dashboard and it breaks their tib over and it opens all that up. And I mean, it's just a nasty, mangled mess. If you're concentrating on that, this is the most painful injury, and you miss the bruising starting in the abdomen, which is the more serious injury. So reassess your patients. Make sure you do that full exam. Don't get stuck on the distracting injuries. Don't get that tunnel vision on that fractured leg, because there's that much force. Probably a more serious problem going on. Sometimes there's not. Sometimes that's all it is. So, but you need to obviously do your exam, right? Ask about changes in symptoms, especially ones anticipated because of treatments administered. Is that helping your breathing? No? Oh, man. Well, maybe a little bit. Okay, well, I'll check back here in a minute. And so, no, for lack of thought, and that's what I got to keep going back to, the airway issue. So, repeat pertinent parts of the history and physical exam. Repeat physical exam to identify changes from baseline, and then check any intervention. You're just going to keep checking. Ensure adequacy of oxygen delivery and artificial ventilation. And then ensure management of bleeding, ensure adequacy of other interventions. So to ensure adequacy of oxygen delivery and artificial ventilation, how do you guys reckon you're going to do that? To ensure adequacy of oxygen delivery and artificial ventilation, how are you going to do that? A good way is through your pulse oximetry. I will tell you this, though. I will tell you this. Pulse oximetry is very delayed. All right. So by the time you get it all the way down to the finger, let's say that they do have a good pulse, it's going to be a delayed reaction. Sometimes your patient will stop breathing and you don't even have a drop in your pulse ox for about 5 minutes. So, yeah, definitely. Look for other signs. You're bagging them. Did we pink up? That's it. Yeah, they sure did. I always tell my CPR classes that whenever you walk in and you see a person in cardiac arrest, they look bad. They're ashen gray. They're pale. They look terrible. You start doing CPR, so you start doing ventilation, all of a sudden they pink up. They look, and you actually get kind of excited. You're like, hey, I might be able to save this person. And 9 times out of 10, you're not. But you get that moment of hope because they pinked up. They look alive again. As you guys learn about capnography a little more, one thing that you will learn is pulse ox will have no bearing on your toes. Don't even put it on. But do put on your end-tidal CO2 detector. Because what you're going to see is you're going to be going along, kicking along, and there's no real CO2 waste made because they're dead, right? So there's no oxygen consumption. The cells aren't really creating that waste. So whenever it measures 5, maybe, sometimes 0. And it measures nothing. All of a sudden, you see a big spike in that end-tidal CO2. It goes up to 25. You probably have a pulse. Now, don't stop your efforts because it might be a weak one. That's a telltale sign of return of spontaneous circulation. Is a spike in the end-tidal CO2. And so it's kind of cool. So you could look at that. Wow. These people look way too calm. I'm going to say this is staged. So check intervention. Think about it. Describe an example of an intervention that might need to be reevaluated in special processing. Each talk about Observing trends. Repeat reassessment steps frequently. Establish and document trends. Trending. Observing patterns that have emerged among vital signs, and then trends may indicate new treatment or adjustments to ongoing treatment. You put them on a nasal cannula because they're at 91%, and it continues dropping. So, do we need to change what we're doing? Typically, it's not going to do that. But we need to change what we're doing. I always felt we put them on a nasal cannula, and it comes up to 96%, and they start to pink up. Do we need to change anything? No, we're observing an improvement. Do we have to get them to 100%? Now, that used to be EMS's goal, by the way. We used to want to get them to 100% oxygen saturation, which is kind of crazy because, well, I know you smokers aren't there, but even the non-smokers in here probably aren't. We're
I was going to say, the last time my sister and I went together, mine was higher than hers.
Well, yeah, but see, you have that 10-15% of your hemoglobin has carbon monoxide on it. So 10 to 15% of that's poison. So, oh, you know what? Everybody's just looking at me. Why don't you guys ever say anything out there? You guys are supposed to tell me, hey, Rob, we're just looking at you rock back and forth, and it's making us sick because we think we're on a boat. Screen sharing. We don't see the slide. No, they're there. There's 1, 2. Well, they're probably not watching. They're probably doing other things like gaming and things like that.
I know. I'm watching.
Or at least listening, right?
Right.
So, all right. So have you been sick because you've been riding the boat with me? As I rock back and forth. Somebody complained about that one day. They're like, "Oh my God, for the first like 20 minutes of your video, you just rock back and forth, and I was getting sick." Well, don't freaking look at it. Nothing makes you sit there and watch me rock back and forth. I find myself though, just speaking of that, like I watch a YouTube, and it's like it's this story, and the guy's sitting there telling it, and I need to do other things. I'm like sitting there watching it, and then I'm after about 3 or 4 minutes, like, why the hell am I watching? All he's doing is sitting there telling a story. I could do my other things and have this sitting over here and listen to this story. So anyway, like get dressed, so I can get here, and have class on time. That happened. That happened just this morning. Yeah, I was watching this video and I'm like, I can be getting dressed and listen to this guy because all it is a camera on him. It's not like it's showing anything. So, all right. I do talk to myself quite a bit. So, I don't necessarily argue with myself because I'm always right, and it's really hard to argue with yourself when you're always right.
My son, my oldest, he said, Mom, I had an argument with myself today. It was so bad, I had to Google it to prove that I was right and they was wrong. He's like, and then I had to re-Google it because there was something else added, and I was like, oh, no, don't tell nobody about that. Like, I argue with myself all the time. I usually just kind of just talking about it.
Yeah, to prove to yourself that you're right.
Yeah.
Oh yeah, I'll prove. So, all right. So
That's exactly what he said.
So trends may indicate new treatments or adjust ongoing treatments. We've been talking about this, so it's not like that slide says they may profound. Reassess and record vital signs. Reassessment for stable and unstable patients. Patient's condition as well as the length of time with patient will determine how often you reassess. EMS is crazy insane on how often reassess. We're 15 minutes for a stable patient, we're 5 minutes for an unstable patient. I have a huge issue with that. If I'm reassessing my vital signs every 5 minutes, all I'm doing in the back of that truck is reassessing vital signs. What is your typical range for nursing? to reassess vital signs. You guys like stable patients like 2 hours or something like
Oh,
that.
yeah.
Now the critical patients, what, 15 minutes or so. And so that's more, to me, more manageable. Because I could do treatments in between 15 minutes. I can't do treatment in between 5-minute reassessments. And so I've always felt like EMS is going a little overboard on the reassessment of vital signs. Maybe if you don't have anything else to do besides sit there and watch it, okay. But even as with you guys, there's a few treatments that you guys are able to do. For me, there's a whole bunch of treatments I can do that greatly benefit the patient, or they outweigh the benefit of the patient than me checking vital signs every 5 minutes. And so I have an issue with it. But anyway, know that it's 5 and 15 minutes, and I think. And I just think that is one of those are the silliest numbers in the world. I've never taken a vital sign every 5 minutes. Never.
I think the book says the only time that you don't have to do it every 5 minutes is if you're the only one. If you're the only one.
And that, okay, sure, whatever. The nice thing about modern technology, though, is we have an auto. I have our auto vital set at 10 minutes. So the only time that sucks is whenever you do a transfer and you're on the road for 2 hours, and then you have vitals every 10 minutes. In ours, because of how it's set up, you have to go adjust every one of those. There's a lot of vitals. It's even a hassle to delete the ones you don't want. But I wish EMS would get more real with it. Every 15 minutes on your critical patient. Yeah, sure. There's patients that I'm going to do a treatment on. Like let's say I'm going to put them on CPAP. I'm not going to check their blood pressure, their pulse, and all that every 5 minutes. But what I am going to do is I am going to watch the waveform capnography, and I'm going to watch their pulse oximetry. And I'm probably, if you want to just get down to it, I'm probably doing that even a little more than every 5 minutes because I'm watching them. Okay, looks good. All right, coming up, yay. And so, but to actually do a full set of vital signs every 5 minutes is insane. It's asinine. So, I think it would just be more uncomfortable because you're actually allowing that blood to reflow. So you're not ever really stopping that flow of blood. Yeah, it's going to hurt. I mean, blood pressures are not comfortable. So when to reassess every 15 minutes for a stable patient, every 5 minutes for an unstable patient, or potentially unstable patient. My opinion on it. Know these numbers for the textbook. But I understand that if you do it in a critical patient every 10, 15 minutes, I understand. So if you believe there may have been a change in the patient's condition, repeat at least a primary assessment. So reassessment is the last step in your patient assessment. You should reassess a stable patient at least every 15 minutes and an unstable patient at least every 5 minutes. It's insane. All you're going to be doing is reassessing and checking vitals every 5 minutes. That's all you're going to get done. So, elements of reassessment include repeating the primary assessment, repeating and recording vital signs, repeating patients' pertinent part of the history and physical exam, and checking the interventions you perform for the patient. I would say for the most part, these are things you're doing anyway without that 5 to 15 minute rule. You're constantly doing something in the back of the unit, especially on your critical patients. You're constantly doing something for that patient. If you're not, you should be. And there's always something to do for them. Check their blood sugar, put a blanket on them, get them oxygen, check their vital signs, reassess your treatments. So there's always something you're going to be doing for them. Interventions you need to check include oxygen, bleeding, spinal mobilization, splints. Always check your bandage. So like you stop some bleeding with a bandage. Always check that. Is it bleeding through? Do we need to add a bandage to it? Or tourniquets. If you've been applied a tourniquet, you always want to check to make sure that it hasn't started bleeding yet. Sometimes it will, and you just need to retighten it. Critical thinking and decision making. Diagnosis is labeled for condition based on history, physical examination, vital signs. Involves both physical and intellectual activity. You're still going to have doctors that are vehemently oppose you giving a diagnosis. We have gone from EMS not giving diagnosis at all. We were just they wouldn't call it a diagnosis, which is always stupid to me. I have to have a quote unquote diagnosis to start treating something. And so last time that I knew, and we'll see with this textbook, they called it a field diagnosis, not a true diagnosis. It's a field diagnosis. I don't care what you call it. It's a diagnosis. You think this is going on by the signs and symptoms that you see, the history, the physical examination, and vital signs. If you didn't come up with a diagnosis, why are you treating it? And that's kind of where I'm at with it. Or respiratory distress. I have unknown etiology. I don't know what's causing the respiratory distress, but I treat it. And so I'm not doing a pinpoint diagnosis. I'm not saying this is exacerbation of COPD, preliminary emphysema, or whatever their big long thing is. So, that guy looks confused. He's like, what? So the traditional approach to reaching a diagnosis include interviewing the patient in controlled environment, a clinic or office. Like I said, you're still going to have those physicians that oppose you to creating diagnosis. They might even be a little shitty about it. Just go on with your day. It's not worth it. Clinicians have different levels of training, experience, time, technology, and other resources. Techniques vary among types of clinicians. How a clinician reaches a diagnosis. They have x-rays, labs, and all kinds of fun things to actually pinpoint what's going on. And sometimes they still can't. Sometimes they're like, I don't know. Take this and go home. So, sometimes they can't even come up with it. So, techniques vary among types of clinicians. The traditional approach to diagnosis medicine: assess patient, list of conditions or diagnosis, differential diagnosis, or the differential. So whenever I say that, we have we're trying to determine between pneumonia and CHF, and we have a fever. They're going to do it a little differently. They're going to do a chest X-ray, and they're going to do lab work, and they're going to be able to tell. They're going to be able to diagnose that way. So you have your ways of doing differential diagnosis. Not always right. Sometimes you come in and it's a respiratory tract infection or pneumonia and CHF. So you have both of them going on. That is possible. So, yeah, definitely. Further evaluation, reevaluate the differential, then your final diagnosis. One thing, and I don't know if they say this in the book, one thing that I feel like is very important to get across is you don't have to determine exactly what's going on with the patient to start your treatment, all right? We do a lot of treating signs and symptoms. Respiratory distress, we're addressing the airway with starting at a more basic level, and then we increase our intervention depending on whether the patient gets better or not. Or sometimes we're like, you know what, a nasal cannula is not going to help this patient. That is apneic. So we'll go ahead and start bagging. The emergency physician assesses patients in the busy, hectic atmosphere of an emergency department. Quickly rule out and treat immediate life threats. The emergency medicine approach to diagnosis. Quickly rule out and treat immediate life threats, and we stabilize the patient. That's what we do. Return together additional information. Focus on ruling out worst case scenario. Red flags suggest problem serious. May be responsible for multiple patients. And so that's kind of a good explanation of what you guys are doing. You guys are first taking care of any life threats, and then you're going to go back and try to figure out what's going on. Must be very efficient, be available for another call as soon as possible. And this is the EMS approach to diagnosis. Must be very efficient, be available for another call as soon as possible, work in an uncontrolled environment, and limited tools and skill set, and narrow educational focus. EMS, we don't deal with sniffles and sneezes, and we're terrible about dealing with long-term illnesses. All right. What we're really good at, and in some cases we're the best at, is treating and stabilizing acute situations such as cardiac arrest and trauma. We're probably hands down, depending on where you're at, in our field, we have hands down some of the best code people, the people that run cardiac arrest out of anybody. Whenever I worked in Topeka, I would have put my skill set of intubation up against any physician in the ER. As a matter of fact, I watched some of them and I was like, whoa. I've helped with the ATLS class, which is Advanced Trauma Life Support classes, where they teach physicians how to take care of trauma. And I've had to teach physicians how to do things such as intubate. And so we have a very solid skill set in that sense. But our skill set is very narrow and limited. These physicians that we're helping do this, they're also very good at addressing sniffles and sneezes and infections and long-term illness and injury. And Ellen probably go on with the different things that I can't even come up with because my skill set is so narrow. I'm very focused on acute problems. And so that's what it is. Follow the same step as emergency physician. Most are abbreviated or limited. Consider most serious conditions associated with the patient, rules them in or out, and then creates a diagnosis. So throughout this class, I try to throw things out there for you guys. And one of the things that I used the other day to help you with your diagnosis is things such as the palpation of a chest and your interview of the patient. So you're having chest pain today. Yeah, oh man, it hurts. Oh, it gets worse whenever, it's hard for me to breathe. Okay. And so, what were you doing when this started? Well, I'm just sitting here watching the game. Oh, okay. Then you hear in the back, we dug the garden yesterday. Okay. So you helped dig a garden yesterday. Yeah. Okay. Take a deep breath. Oh, yeah, that makes it worse. Okay. Starts popping. Oh, yeah. You just recreated that pain. You have a good story. You can really start to rule out a cardiac issue. 100%? No. But everything's pointing towards that it's a musculoskeletal versus a cardiac issue. And so therefore you ruled some things out and you created a diagnosis. Now through reassessment and continued treatment, you're like, you know what? He is complaining of chest pain. I'm going to run a 12 lead. Then it says acute MI suspect. Oh, wait a minute. I just changed the whole game, right? We went from thinking that, and by the way, 12 lead is another thing that I said, always got to eat my words. I was that medic that said, it'll never change how I treat my patient. I'm going to treat a suspected cardiac chest pain the same way, no matter what. No, it completely changed how I treated my patient. Whenever you put a 12 lead EKG on somebody and it says acute MI suspected, or if you learn to read them and you see that ST elevation, 2-3 boxes of ST elevation, and it looks like a pad MI, you tend to work a little faster than you do on that. Okay, they might be having a heart attack. Case in point, we had a guy that we got to check these to make sure. I was working at Topeka, and I was a fairly new paramedic, and we get a call to a fire station, okay. So we get there, and what happened was the guy went to the ER. They checked him out. He's complaining of his chest pain and shortness of breath. They told him that he had bronchitis. Oh, it's just your bronchitis. Here's you some medicine, and they sent him home. I don't know whether they did 12 lead or labs or anything. I have no idea. So I get this story, right? And so I'm thinking, well, okay. And they're like, we don't want to go back to, I think it was Stormont Bell. We want to go to St. Francis because Stormont Bell didn't do anything for him. And he's really having a hard time. Like, okay. And so, new medic. I'm like, I'm going to go ahead and do a 12 EKG on him, even though he just came from hospital. So it should be good. They should have done all these things. I put the 12 EKG on him, and it went from this, type call to, we got to go now. He's having a huge MI. As a matter of fact, I got for the first time got to see an evolving MI. So we started with 1 to 2 blocks of elevation, which on 12 lead, or on EKG paper, there's little blocks. Each elevation tells you, each block of elevation tells you something. It's a certain deflection, and it kind of shows you that injury like starts small, so it's like 1 box because now the deflection's off a little bit. As it gets bigger, as the MI gets bigger and grows, those boxes it gets more and more boxes of elevation. So you have a baseline with an EKG, and as it goes up from that baseline, that MI is evolving or growing. And so I got to watch this guy's MI grow, evolve, and despite my treatments, morphine, nitro, monitor IV, morphine, nitro, Mona, or vomit, Vitals Low 2, monitor IV transport, and then Mona, morphine, oxygen, nitro. Anyway, and so we watched it evolve. They have us go to room 3, which they're set up so that 1 and 2 are their severe patients. They're big traumas, they're cardiac arrests, or things like that. And they sent us to 3. Okay, and so anyway, they put us in 3. So I had my partner move over, and I take the 12 lead EKG over to the doc because he needs to be in 1 and 2. And I set it down, and they're like, "Oh my gosh, get him into bed 2." And so I go in there to tell my partner, and I watch my partner get ready to move him over, and I watch our monitor go beep, with VFib. I'm like, "Ugh." So we had to code this guy, got him back, and saved him, because he's in a freaking hospital, and we started right away. But point is, number one, that things change. So there's a chance I ran a 12 lead EKG at the one hospital, and they didn't see anything in it, because whenever I got him, I got to watch it evolve. So it grew. It's hard for me still to this day to believe there wasn't something already there. There wasn't something in the labs. Ellen, correct me if I'm wrong. There is a certain window where they go back to normal. The labs go back to normal before they really start to climb. Maybe he hit that window. I don't know. But he went from, and it changed. 12 lead EKGs have changed how I run my calls. But also doing my assessment helped me with that patient and the reassessment. Long story to say all that, but some of these stories are, I think, very interesting for EMS because they show a lot of things that I talk about. So, you can reach a diagnosis, but your work is not done. Why? It may change, yeah. So we may just have a non-cardiac type chest pain that we think, and it evolved into a full-blown cardiac chest pain. Oh my God, my wife must be bored at work. Okay, so anyway, the highly experienced clinicians approach to diagnosis of medicine. Experienced clinicians learn heuristic or shortcuts, pattern recognition, features narrowing possibilities, allow efficient diagnosis and prompt treatment, realizes limitations of shortcuts, and understands common biases of heuristics. I like to call it tunnel vision, and I get it too. So I'm looking at this issue. Sometimes I'm focused on that, and I completely miss the big picture. Not very often. I can't think of a specific case to tell you. I'm just trying to admit that I do have faults, which is hard for me to do. No, I'm sure that I have missed things by using heuristics. By this patient presents like a previous patient I've seen with these types of complaints, and maybe there's something else going on. But
That's important on the test. That H word,
heuristics.
yeah, that's on the test. Proof is, just for those who haven't taken it.
Quit helping them.
It's the thing that looks like it does, it tracks like it does, it makes it does, except when it isn't.
Yeah, exactly. There's always an exception to the rule, and so understand that. So common heuristics. So representativeness. So that's the duck. So it looks like the duck, right? Quacks like a duck, but it's a duck-billed platypus. So exactly. Availability, overconfidence, confirmation bias, illusory correlation, anchoring and adjustment, and then search satisfying. So basically, what they're trying to say here, correct me if I'm wrong, but is that sometimes we want it to be, or we think it's this, so we make it fit this, and we maybe ignore some things that don't go along with it. With let's say like the we want it to be a musculoskeletal pain, so we make it fit a musculoskeletal pain, and we ignore some of the things that say no, this is actually a cardiac event. And so be careful with that. They used to call it tunnel vision. I'm guessing that's what we're talking about right now. I guess tunnel vision would be a little different because I'm just focusing on that bone sticking out of your leg. I'm not, whatever. I'm not going to watch this video. I don't think decision-making information video. How an EMT can learn to think like an experienced physician. Learn to love ambiguity. Yes. Understand the limitations of technology and people. Realize that no one strategy works for everything, and then form a strong foundation of knowledge. What's that? You're like, man. Organize the data in your head, change the way you think, learn from others, reflect on what you have learned. All right. So I think that's all part of what I would like to call experience. All right. They're like saying, hey, let me go back here. No, I said that. Yeah.
Is what it says.
But here's my problem with that.
I'm a nurse. I'm not supposed to think like a physician.
God damn it. Go back.
It kind of got me.
It's hard to organize the data in your head if you're so flustered because this call has you. Next, let's say a year later, you run the exact same call. You're going to run it better because you have that experience. You have to almost experience some of these things before you could become this experienced, treat like an experienced physician. We're never going to be as good as those guys at diagnosis. That we are better than some, but for the most part, I always got to give props to physicians because I was actually going to go to med school, and so I go through and I do everything, and I do organic chemistry 1, which I love, which is crazy because most people say if you get through organic, you get through med school. I love organic chemistry 1. I didn't love organic 2 in the summer, but that showed me what kind of lifestyle I was going to have for the next 6 years. And so I decided not to go to med school because I had kids. I wasn't going to give up the time of my kids to be a doctor. And organic 2 really made me question my ability anyway. I mean, I studied and only got a C in the class. Of course, it's over the summer and it's super fast and stuff, but I really question, do I have what it takes? So I have a high level of respect for the guys that have gone through that process, that they've gotten through all the prereqs, which guys, the prereqs to get into med school aren't a cakewalk. Med school, if you go and tour med school and talk with these student doctors and walk around their campus, you could hear things. When you walk around and see what these kids are doing to become doctors, you're like, oh wow, they're dedicated. I didn't have that dedication. And so I don't ever want to come across as bagging on a physician, even though there are times that my skills are better than theirs, but their knowledge far out, is beyond mine. Now, some of them become lazy and they stop doing what needs to be done to take care of patients. It's not because of lack of knowledge. They to get through the testing and stuff they do, they have to have that knowledge. So they become lazy. And skill wise, they're not. That's what I do. I'm skill based. They're knowledge based. A lot of times if they don't have some sort of reason to want to learn to intubate, they're going to be terrible at it. I've done it a lot, so it doesn't make my knowledge more than a new anesthesiologist. Those guys, even though I've sat in class with them, whenever I was flying, we had to go and do rotations with the med student, and so I'm sitting there and I'm like, I couldn't believe some of these guys are. You're an anesthesiology student and you don't know what the only depolarizing paralytic is in the U.S. I'm a little scared, but anyway, I don't ever want to give the impression that I think I'm smarter than a doctor. I don't. Sometimes my skill set is stronger because I have a very limited skill set. Anyway, back to this. You have to have the experience, I feel, to get here, to do these things. You have to go through the experience. You're going to have to go through the period of time. Now, Ellen, it might be a little different. She's a nurse. She has that experience of assessing a patient. And Rebecca, she is a very, kind of listening to her talk about dealing with her patients. She has a skill set of assessing patients that is above and beyond mine. And so these people like this, and maybe some other people, I think they have some nurse aides or something here. They're going to get there a little quicker than the people that are just brand new EMT basics because they've already had the experience of evaluating a patient and coming up with their diagnosis or what they think is going on with the patient. And so they're going to get there faster. But I think it boils down to this: you have to have the experience to get here. So I think it's kind of naive to think that I'm going to be able to say this on a slide and you guys are going to be able to just turn around and translate that into real life experience. It should, but it doesn't. Even though I did hear something that I felt like was very interesting, and I don't remember where I heard it. I don't know if I kind of listened to Cindy on a conference call or whatever for just a brief period. And what they're talking about management and things like this. And one of the things that was said was on the conference call, a question was asked about how does the doing their like assessments or practice runs. What do you call that? Anyway, how does that translate into real world experience? That's not the same. And she said, well, actually, studies show that by doing these scenarios and practicing even on a mannequin, and I've translated the word mannequin, but she said that the brain doesn't know the difference between an actual and a practice run. You're still gaining that experience by doing that practice. And so if we practice doing blood pressure, we practice doing patient assessments, you actually become better doing patient assessment because your brain doesn't know, your brain doesn't put it over here, well, this was just a scenario and this is real. You've been doing it, so you get that experience. I thought that was very interesting.
Just like kids, when they hit off the teeth, they get used to that motion.
Yeah, that batting motion.
Yeah, and
Yep.
it's safe, but it's not. When they get used to it.
So think about it. What are some of the important things to remember as you learn how to make a diagnosis and improve your critical thinking skills in EMS? I think we kind of went over those. I don't know. I don't feel like doing it again. So. Leadership video. Anybody want to watch a leadership video? Yeah, me either. Delegating. Now, I do need to watch delegating authority video because that's fun. I need you to do this, and I need you to. I'm good at it. Exactly. So chapter review, blah-de-da-de-da-de. I'm actually going to read these because sometimes I feel like they put it in a good way. So EMTs make some diagnoses in the field, although they are not as extensive or as detailed as the physician diagnosis. That's true. I could get behind that. And I kind of said that whenever I just made up this big, long diagnosis. But if you want an example, look at the new ICD-10 codes. Oh my gosh. It's ridiculous. No longer can we, even in EMS, put, oh, they had breast cancer. You have to know exactly what type of cancer caused the breast cancer. And whenever you're getting a history from a patient, they don't even know. I think this is the stupidest thing we've ever done in healthcare because now my people just don't put in medical histories. We have to type it in. So the tradition. Well, go ahead.
Trauma registries like that.
It's ridiculous.
It's down into knowing exactly, we almost have to pinpoint exactly where the accident happens, and out in the field, you can't pinpoint. I mean, you're just
a puncture to the foot from a nail sticking through a board that the nail is rusty, the board is weathered. I mean, it just goes on and on and on. I think there was one like attacked by a duckbill platypus while swimming in a river. It's like, what? That crazy thing is this has happened enough that we actually have to have a ICD-10 code for it.
Was it cold weather? Was it hot?
Yeah. It's just ridiculous. You know, I know why they're doing it. It makes it easy for these epidemiologists to study this crap, and so you know they could do more pinpoint studies for people rather than just these broad studies. But I question whether I question whether they're going to be able to actually do these studies because whereas they used to have good data, it was broad data, but it was good data. Are they going to be able to get the data now? I just don't think they're going to be able to get the data. You know, it's like EMS, we just select shit because. Okay. I'm sorry. So we select things just to get our chart filled out, so it doesn't have. So we're at 100% versus 98% validity, and so we're just selecting things. Well, now our data isn't. It's skewed exactly. It's skewed. So the traditional approach to reaching a diagnosis is to assess the patient, draw up a list of differential diagnoses, assess further to rule in or rule out differential diagnosis, and narrow the list until you reach a conclusion. I'd say this is still a way of doing the way that we do it. It's just we're ruling out a lot of things before we ever even start, simply by our questioning of the patient. Our brain is already throwing things out, and yes, it's not making a list, writing it down, but we already. If I have a patient that has respiratory distress, I've already thrown out a lot of things that I could. Now I'm narrowed it down to my few respiratory diseases that I'm familiar with, and cardiac. And then from there, I maybe throw out cardiac. I narrow it down to about 3 my respiratory diseases, and I go from there. But it's all done like that, you know. And so I think that's still kind of how we do it, even though they're going to say we do it differently. It's still done that way. Highly experienced physicians don't always use the traditional approach. They use heuristics or shortcuts in combination with their experience and training, which speeds up the process of reaching a diagnosis. Shortcomings of heuristics include representativeness, anchoring and adjustment, overconfidence, confirmation bias, illusory correlation, and search satisfying. So they're going to make even though it don't exactly look like a duck, they're going to make it a duck, but it's really a Canadian goose. So anyway, Learn to think more critically by accepting the ambiguity of EMS working conditions, understanding limitations of people and technology, forming a strong foundation of knowledge, and organizing the data in your mind. That's kind of what I was saying. You're going to be working this in your mind the whole time. EMS is very ambiguous, and sometimes it frustrates the hospital. But geez, sometimes this is all we have. We're sorry. And I think from whenever I started EMS to now, and I've worked, and I've delivered patients to big hospitals. I think the relationship has become a close relationship. Nurses and paramedics still like to razz each other and give each other a hard time because we do have differences. But I think for the most part now we understand each other's differences. You still get that old school nurse that you just want to choke out, and chances are if you get to talking to some of the other nurses, they also want to choke this nurse out too. So don't.
They've done this way for 100 years.
Exactly. And most of the new ones are like, oh my gosh. And so just know that there is a change of guard. That nurses and paramedics and EMS professionals, I feel like we've become closer. We're actually, as before we were playing for different teams, now we're at least supporting each other's teams. And so, and I think the relationship will become closer because you see a lot of people fulfilling dual roles. You see a lot of people becoming nurse paramedics or paramedic RNs and doing that dual training. You see with EMS, a lot of our stuff has gone to, and I know I'm off on this shit. You see a lot of our stuff going more towards evidence-based, so ours is aligning more with theirs. And so you see the relationship becoming a lot better. I feel. When considering the cause of a patient's condition, don't let your search for a cause delay your treatment of the patient. I think I've said this a million times. You don't have to have a diagnosis to start treating the patient. If they're having respiratory distress, address that. You don't have to know exactly why. You're gonna work it out because it's always a great feeling whenever you ruled it down to pneumonia and you get there and they're diagnosed with pneumonia. Whenever I was a paramedic student with the crews, it was always a game of ours. I always had to come up with a definitive diagnosis for what the patient was. So that I'm thinking through this patient call the whole time, and they had the reason for doing it. They're jerks. My preceptors were jerks. And they were very big jerks. But two, they made me think about the call the whole time I was running it, and so I was trying to narrow it down. And it's always really good feeling whenever you get that right. So we had the patient that had a sudden onset of chest pain, went unresponsive and snoring respiration, and they had surgery 2 weeks before. And so the guys are like, "So what do you think this is, Rob?" I was like, "This is a pulmonary embolism." What? Why would you think pulmonary embolism? Textbook case. Sudden onset of chest pain and followed by unresponsiveness. There's some other things, and I said, and he had surgery 2 weeks ago. They're like, no. And so anyway, they get the lab back, and they're like, "That looks like a PE, guys." And Rob, like, yeah, in the ER room, and the ER staff kind of looked at me like, huh? And I was like, sorry. That's what and they're like, "Oh man, you got them. Oh, you just got lucky. You got lucky." Like, it was textbook. So, anyway, it's always good. It always feels good to get that diagnosis. But don't delay the treatment to get that diagnosis. Use mechanisms of injury to determine the need for a rapid trauma assessment. Assume spinal injury, and then work as a team to complete the assessment. That's one thing I'm trying to work with my people on. Is I don't need you hovering over me while I'm doing something. There's other things you could do. You could get names, date of birth, allergies, medications. You could fill me out a whole list of paper. That's one thing I like about big services is big services, they have the training department to help do this. But with big services, if it's my patient, I go right to the patient, and you're going to go to the family or bystanders, or you're going to be my gopher. If it's your patient, you're going to go to the patient and take care of it. I'm not going to hover over you and answer questions on top of yours. This is kind of to help you guys out. If you want a patient to be leery of you and your team, both of you start firing questions at them. They don't know who to talk to. They're confused. Another thing is then you start doubling up your questions. They're like, who are these clowns? They're asking the same questions over and over again. And I'm not sure if we've gone over this yet. You guys, if you ask a question, be ready to listen. All right, be ready to listen to that answer. I've been guilty of this. Have to ask like date of birth more than once, or age. How old are you again? That's my bad. I should have stopped and listened. And the reason is if you don't, they are going to start to question your abilities. And so, anyway, get into the rhythm of there are exceptions to this rule, but get into the rhythm of if they're a patient, they're going to interview the patient and do that. You're going to go get information wherever you can elsewhere, not over the top of them. And it helps out a lot. So sometimes you find out there's two stories to what's going on. The patient's lying to you. They accidentally did an overdose, and the family is, oh man, they've been depressed for a month now because so and so lost their job or whatever. And they said they're going to kill themselves. Oh, so, now we have probably not an accident. So how did a focused physical exam of a trauma patient with a significant mechanism of injury differ from those for a trauma patient with no significant mechanism of injury? With the one without a significant mechanism of injury, we are going to go ahead and do that detailed physical exam, right? That detailed head to toe. Whereas with a severe MOI, we're probably just doing that rapid assessment, right? List of steps and areas covered in the rapid trauma assessment. How are these steps different in a detailed assessment? That's probably where you guys need to read, because I don't know what the hell the difference is. Besides, from the slides, what they say is that you're going to do it more in depth. Well, okay. Does it tell you in the book what they mean by that, more in depth? Okay, they do. What do they mean by that? You're just going to take more time with it? Or? Okay. Yeah. You are assessing a patient who fell 3 stories. He is unresponsive and bleeding into his airway. The driver of the ambulance is positioned the vehicle and bringing equipment to you. Good job, driver of the ambulance. No longer do we have ambulance drivers. Everybody on there should be an EMT, unless it's a critical call and you get somebody like a fireman to drive. One thing that drives me insane is whenever people are like, oh, you're an ambulance driver? No, I'm not. I'm not an ambulance driver. An ambulance driver fell out of favor with the state several years ago. And it was a evening course where you learned how to drive the ambulance. I'm a paramedic. I went through a shit ton of school to be a paramedic, and I'm not an ambulance driver. I don't even like driving the ambulance. For my first year, I didn't even sit in the driver's side of the ambulance because I was driver basic team. That guy drove everywhere. That was his little station. I don't drive the ambulance most of the time. No, and you guys will only drive it 50% of the time, so you're not you're an EMT. And I know they don't mean anything by it. And you get to a point where you're just like, yeah, I'm an ambulance driver. Just go along with it. Just because, kind of like Jacqueline for pharmacy. They're like, so is that on-job training? Are you teaching Jessica to be a pharmacist? And Jacqueline's like, yeah, I have my PharmD. I have my doctorate in pharmacy, but it's on-the-job training. It's just people. They're ignorant to it. It'd be like me trying to talk about an underwater weld. So you went to Tulsa welding school to do that? And no, I don't know. They might have that program there. Completely different game, underwater welding. Something about being in the water with the electricity. I don't know. Those people. Do you know somebody that does underwater welding? Does he? They get. I think it'd be a fun job if you knew how to do it. Yeah, underwater welding. Because aren't they in those the old looking bubble helmets, and they're attached to a tether up top, and it'd be cool. Welding's awesome. I love welding, but I don't know enough about it. I would offend somebody if I could talk about welding to them. So. All right, let's take a little bit of a break. I think we still have plenty of time to get through the other chat. I gotta go to the bathroom. So. Yeah. Man, that's awesome. Yeah. Do you have games on it? Yeah. Can't beat a pink case. Yeah.
Guess what?
What?
My little Alex, my little brother, you're taking my dad.
Yeah. That's all right, huh?
Some boys do like me.
Yeah.
That's true.
Some boys do. You like purple too?
I like all the
You don't like gray? Yeah. Show is. You like gray's all right. You just not one of your favorite colors, right?
Yeah, red, white, yellow, black, red. All the colors versus red. I still like gray, but I don't like it.
I gotcha.
So, yeah. Tell me like everything now.
Yeah.
But all I know is that not that
What's up, Mitch? Do it. Okay. Should be. Okay.
Angel tried the other day, looked at the market.
I think she's full of it.
You're not full of
Yeah. You're in trouble.
it.
Oh,
We got one up next to me too.
might be over here or something. When you start in the paramedic program, you guys got all your prereqs done.
She's still working on her math. I'm doing A&P this summer.
Yeah.
I'm not sure how smart if I don't know how to do the summer semester.
When did you do that?
Do that and whatever, just all that P1 and PCG and stuff.
Yeah. I mean, it shouldn't be terrible. A and B is not hard. Physiology can be. There's a lot of memorization. You start talking about citric acid cycle and things like that. But,
I wish I had my paramedics already Saturday.
oh yeah,
Well, I made 3 runs.
Here?
No,
at least.
same person twice.
Yeah.
Burger King took it as friends. They come there. Oh yeah, you're sick, but they're sending people out there to use our social media. You gotta leave.
Wow.
They say, and come show the right.
Yeah.
They only 6 hours over there, and come over and get my certain value. We like to do it very well, get my fluid come in. They get the fluid all from the garden. They go out, take a sip.
They give her Zofran.
Like, he's not necessarily like, you know, they, big rotating and trees.
Crazy.
I think they're really expensive.
Yeah.
He
Yeah, that's kind of crazy. Yeah. Breathing all right.
It was like 35 minutes before I got there, because I was laying on the floor.
Yeah.
Just breathing, long time breathing.
Yeah, that's probably what, I mean, I would have gotten to just listen. We had a kid one time, and parents today driving, turn around, the kid like has a handful of money sitting in his mouth, like coins. So mom freaks out and gets all the coins out of it, you know. Anyway, she said, and then he just started doing this drooling thing. And kind of get like a horse breaths and some drooling. Okay. And so, we'll take him in and watch him and stuff. If something happens, we take care of him. There's not a whole lot we do. So kids strap him and mom and the kid in the captain seat and sitting there and he do this and all of a sudden he starts drooling everywhere. So we're sitting there driving and he starts doing that one time and all of a sudden the penny goes ting, ting, ting. Popped the penny up, stopped all that, and she's like, do I still have to go with you guys? Or like, if you don't want to. Son refusal pulled over and she got back in with her dad. Yeah.
I'm not leaving until you sign a refusal. I mean, the paper, they don't sign it.
I can't believe she didn't sign. I mean, all they just tell her all this is the same. You came and looked at it and you don't want to go by me.
Have somebody there to walk up and they go to chicken.
Oh, yeah.
Certain kind of bird chicken.
Chicken in the house?
It was when I was there. So, Mickey Mouse is my favorite thing.
Yeah, that's what we do. If you're not on there, let me know. I'll see what I can do at our next break. Let's see how many slides this is. You guys say this is short. It's still 70 slides. Yeah. Oh, plain language now. No more 10 toes. Even though all these idiots out here do. You use 10 toes, man? I always say, what's that mean? I don't know what any of it means. When did you page this out? What time were we on scene? What time were we up to? What time were we on scene? Time to leave the scene. Time to ride to the hospital. All right, communication and documentation. Chapter 15. We'll try to it's a little blurry again. Try to get through these. So here's the topics: communication systems and radio communication, the verbal report, the interpersonal communication, pre-hospital care report, and special documentation issues. I'm not exactly sure why they combine these two slides. I feel like the radio should be in operation, and I personally feel like documentation should have its own chapter. So I'm not sure why they did. As you've heard us just now talking, yes, 10 codes are still being used in rural EMS, but they're not supposed to be. We are supposed to be using plain language now, EMS RMMH 3336.
No, that's not plain language.
And
That's got a form up there.
if it's either a capital E or a little e, I don't remember. So, yeah. So, anyway, we're not supposed to be, they have found that plain language is just as fast as using PIN codes, and it also has the advantage of if people come into your system to help out, or you go into another system to help out, that you guys can understand each other, because PIN codes are not the same throughout systems. So it is highly recommended that you don't use PIN codes. To the point where I don't even care what the PIN codes mean. So I don't know what they mean. Where they say or 97. Well, what the hell does 97 even mean? PIN 97. I don't even know what that means. Yeah, I don't. But the thing is I don't care what it means. I use plain language. Communication systems and radio communication. EMS uses various communication systems: radios, one-way pagers, cell phones, and traditional telephones and landlines. You're starting to see a lot of the pagers go away just because that's an additional expense that's not really needed. Now, a lot of your dispatch systems could send the messages to a cell phone. And so cell phones are really becoming kind of the go-to way of communicating. But we still have radios because in times of disaster, maybe a cell phone tower gets knocked out or whatever, and you still have radio communication. There are different ones, like they have different things like encoders, which basically will make it so that we're talking on this one station, but like I forget what Roger Mills' number is. It's like 253 or something like that, 256. You have to hit 256. Well, whenever you key up, that then opens up the communication with Roger Mills radio, which I don't think you guys even have encoders anymore, because when you guys bought that new system, I don't think you guys have encoders put on. So,
No, we just have that.
yeah. They went back to the encoder system after Hurricane Katrina because all communications were knocked out. The only communication that would work is the encoder system. And so it's an old, antiquated system, but it worked in a disaster. So all of a sudden we had to have it again. I think it's going away again. I don't think we're required to have it anymore. They are starting to do a lot more different ways of communicating through these Wi-Fi. I don't know. It's new. I don't know enough about it yet to talk about it. So I do know that it's coming through. EMS radio systems consist of base stations, mobile radios, portable radios, repeaters, cell phones, and telemetry. A base station is basically a station that sits at a base at the sheriff's department. It doesn't go anywhere, never moves, sits in one place, and they talk to you. Typically, whenever you're talking about this, it has the most power, a lot of times connected to the antenna. Then from there, it goes and hits what they call a repeater. Repeater simply takes that signal and repeats it and rebroadcasts it out. So if the Roger Mills base station hits the repeater down on the river, all of a sudden you have that signal going out all over the river, and it extends the range of the radio. So a base station, I believe base stations are around 100 miles of range, but don't quote me on that. Read the book. But with a repeater, you expand that range. Mobile radios are radios that are mobile in a vehicle. They're like what's in the ambulance. They have less range than a base station, but they're always moving. They're always hitting a repeater. There are some places that you won't hit a repeater. You'll be in a black or a dead zone. Portable radios are the ones you see everybody carrying their hip. They have even less range. A really good one has like up to a mile of line of sight range, so you have to be within a mile of being able to hit that repeater. Out here in Roger Mills County, they have enough repeaters set up. And the repeaters range makes it so that you're able to hit most any repeater with a mobile radio. Cell phone, everybody knows what a cell phone is. Still have to have the towers, just like the radios do. They have the cell phone towers. Hey, how's it going? And then telemetry, I'm guessing is just a way of communicating imagery over radio frequencies. So, yeah, there's a kind of an example of what I was talking about. So.
Yeah, that's very important for people listening.
This is very important for the people that are listening. So, yeah, the portal radio hits the repeater, goes down, can hit the base station here from the repeater. So. Regulated by the Federal Communications Commission, the FCC. They don't really favor you cussing on the radio. It's really kind of a no-no. Establishes rules regarding appropriate language. Not only like I said, cussing, but also the plain language. One thing, and then they monitor radio traffic. One thing we're really bad about out here on the fire department is they will go and they'll stay on a transmitting station. So like Roger Mills Civil Defense, or the emergency communication station, whatever you want to call it, that pages everybody out. Fire, EMS. Fire departments are really bad about staying on that channel and chatting when they're fighting fire. They have what are called TAC channels, or line of sight channels, that don't hit a repeater, so they're not broadcast. Problem with them doing that is they're hitting these repeaters, and so everybody everywhere hears them. And so what do my EMS people have to listen to whenever they're trying to listen for a call? They have to hear about these guys fighting a fire. And so that's something that really should be regulated, or is regulated by the FCC. They set up these TAC channels for these guys to use, but we're really bad about using them. And you talk to them, and it's because we don't have a solid understanding of what these radios are what they can do. We don't have the understanding that our mobile radios have about a 5-mile range, and so if we have a TAC channel, we could fight this. We could hit it. Now, state fire is a statewide freaking frequency, so they could jump over on state fire and talk to each other. Once again, it's not hitting repeaters; it's just line of sight, but it's 5 miles. You're talking to somebody on a fire line that's 5 miles away from you. Their situation is different than yours. They probably don't want to hear you talking either. So, anyway, our fire departments would benefit from moving on the TAC channel. It would benefit the whole system. They tackle other video traffic with it. So, principles of radio communication. Make these following principles when using the EMS radio. Oh my God. That's insane. Make sure that your radio is on and the volume is adjusted properly. I'm guilty of this. Having the radio turned down for whatever reason and not hearing whenever you try to talk into it. You don't hear whenever they respond. So make sure that you at least have the volume up. Reduce background noise by closing the vehicle windows when possible. Also, if you have a handheld radio, turn it off before you key up on the mobile, because you're going to get a lot of feedback. Listen to the frequency, ensure that it is clear before beginning a transmission. This is something that we're not very good at out here. We just want to talk on it, so we push the button and we start talking. And if you guys ever listen to radio traffic, you hear it go, and then you hear them talking. Well, what's happened is they just walked on somebody. So not only did the dispatch wasn't able to hear what the person that was talking say, the end of it, but they also didn't catch the beginning of the other person was saying, because it shuts down that communication. So you need to be courteous and not walk on. Press the talk button on the radio, then wait 1 second before speaking. This prevents cutting off the first few words of your transmission. So if you ever hear somebody if you hear like let's say like Roger Mills unit, or whatever, what's your number? So 920 Roger Mills, the sheriff's department. And if you ever hear, and that's the normal,
Just half my number.
you get half her number, or you just hear to the sheriff's department. You know that she just picked up the thing, push a button, and start talking. It takes about a second for it to break into that system, open up those channels, so the communication will happen. So 1001, 920 the Roger Mill Sheriff's Department, and then let off, and then they'll respond. So make sure you give that a little bit of break. That one's for testing. Yeah, and it's important for people to be able to hear you. Speak with your lips about 2 to 3 inches from the microphone. That's that way they could hear, or they don't sound muffled until you have it too close. When calling another unit or base station, use their unit number or name followed by yours. Dispatcher, this is ambulance 2. So we should be saying, I guess that's how we should be doing it, where we don't do it correctly. So Roger Mill Sheriff's Department, this is 902. 902, go ahead. If the unit you are calling tells you to stand by, wait until they tell you they're ready to take your transmission. Speak slowly and clearly. Sometimes it's hard. We get excited. Unit 21, I didn't catch all your traffic. Please repeat. Well, we just wasted a whole bunch of time, didn't we? We were trying to be fast and we were excited, and they didn't catch any of that. So sometimes it's hard, but take a deep breath and talk nice and slow. Keep transmissions brief. If it takes longer than 30 seconds, stop at that point and pause for a few seconds. So emergency traffic can use the frequency if necessary. I'd say you probably, for the most part, on our station, shouldn't be talking that long on the station. Use plain English. Avoid codes. I already told you guys why. 10 codes they're not the same from system to system and service to service. So if somebody comes to help you, they might not understand your codes. If you go somewhere and you use 10 codes, they don't understand you. I was kind of got embarrassed as a new medic. We didn't have this in our book either. And so I'm working at a service. I'm working in Topeka, and I get picked up with Sedgwick County. So now I have 2 jobs. Well, I've been working at Topeka so long, I use their 10 codes and confuse the shit out of dispatch. And my partner looks at me like I'm crazy. And then I realized that, hey, 10 codes aren't the same from service to service. Kind of a bad way to learn that. So anyway, especially when you're trying to make a good impression. Do not use phrases such as "be advised." These are implied and serve no purpose. Just takes up more radio traffic. But you'll hear people use it. You hear our dispatch use it. And one of them is an EMD, emergency medical dispatcher. Courtesy is assumed, so there's no need to say please, thank you, and you're welcome. Once again, we're Western Oklahoma. It's hard for us not to do that. When transmitting a number that might be unclear, uh, 15 may sound like 16 or 50. Give a number, then repeat the individual digits. Say 1515. Anything said over the radio can be heard by the public on a scanner. Do not use a patient's name over the radio. For the same reason, do not use profanities or statements that tend to slander any person. Use objective and partial statements. And that's going to be important for your charting too. Partial or objective and partial statements. All right. One thing, whenever I first came here, and they're getting a little better about it, they would not give us nature call because they gave us patient's name. Well, we can't give you nature call. We gave their name. That's a HIPAA violation. No, the HIPAA violation is that you use the patient's name. That's a HIPAA violation. I need the nature call to be safe. And besides that, it's not a HIPAA violation. It's an incidental. It's incidental. It was accidentally overheard, if you will. The public's not supposed to have that station, even though they do. But I need the information to run the call.
Even though everybody in town will know it all by the time everything's done.
This is true, but we don't need to further that. They've gotten better at not giving the name and giving an address in nature call. Mainly because we were always asking nature call. Because I have hounded and hounded and hounded my people about scene safety. We're going to these calls not knowing what they are. Just because we're rural doesn't mean that bad things don't happen out here. We have a drug population. That is a fact. We actually have a dangerous drug population. Meth users are dangerous. Or can be. Not all of them, but they can be. And you could get yourself into some bad situations not knowing the nature of the call. We've had shootings out here. We've had stabbings out here. And not just that, we have psych patients. And these are dangerous situations. Sometimes people are just having a bad day, and you don't need to get involved with that. And so they've gotten better about giving us what we need. Use we instead of I. As an EMT, you will rarely be acting alone. Affirmative and negative are preferred over yes and no because the latter are difficult to hear. Give assessment information about your patient, but avoid offering a field diagnosis of the patient's problem. For example, say patient complains of abdominal pain rather than patient probably has appendicitis. That's important whenever you're calling a report to the hospital. And understand that whenever we're giving reports to the hospital, we're using line of sight radio. I typically use a cell phone. So we're only able to hit them about 1 to 5 miles out. And that doesn't give them a lot of time to prepare for the call because it doesn't take you long to cover 1 to 5 miles. And that's about as far. Sometimes I'll try to start turning about 10 miles out, Rocky Mount Ambulance, Rocky Mount Hospital, and then I'll get a response. I'll wait a little, Rocky Mount Ambulance. And finally, sometimes about 6 or 7 miles, you get real staticky. I'll wait a little bit longer because they're not hearing me very well. I'm not hearing them very well. And so it's kind of pointless for me to give a whole report. And I only do that when I don't have cell phone access, which cell phone access is actually getting better out here. I don't know if they're putting up more towers, but I've noticed that I'm able to use the cell phone a lot more than I was when I first came here. Avoid slang abbreviations that are not authorized. And what you guys are going to find that for the most part, a lot of your abbreviations have gone away. Charting and stuff has gone to plain language as well. It reduces errors, and everybody that reads it understands what it says. Use EMS frequencies for only authorized EMS communications. Don't call your partner on the EMS channel and tell them to pick up some bread and soda pop while they're at the grocery store. We have tap channels for that. Radio transmission throughout the call. Initial call often comes via telephone, but may be radioed from another agency. Without prompt and efficient dispatch and receipt of information, ambulances can be sent to the wrong location. It happens out here. We get these weird things like guy's last name's Hammond, and he lives on Highway 47, and they call us to Hammond on Highway 47. Luckily, a lot of people know the highways around here. Like, wait a minute, that doesn't jive. It's Mr. Hammond over in Raiden on Highway 47. Highway 47 in Raiden? Okay. So I don't know my highway. No, hell no, I don't. I get so confused with 47 and 33. It's ridiculous because they cross. So it's like 47's up here, and then it crosses, and 30. So I don't even try. I just get on the map. I use the addresses and figure out where it is. So, but anyway, you do have that. You do have things such as that, and that one is a true error that happened. Luckily, the person on knew it, or did they call the unit and say, "Hey, you guys are going to Raiden, not Hammond. This is Mr. Hammond from Raiden."
Was there one that they got that was actually a lead call?
That happens a lot.
Like it was lead call, but it got changed out like we were supposed to go somewhere. You get in your ambulance and you take off, and they're like, "Oh, send it out here."
Yeah, and it's because of that stupid 4733 cross. It messed it up.
No, it doesn't base it.
So if 2 units transmit simultaneously, only one will be heard by listeners. And actually, my dad's calling me. He'll just jump away. He must have just read the. He probably just read the text that I hit a deer on the sports tree last night. He probably just now read the text I sent him last night, so he can wait. So, anyway, without prompt and efficient dispatch and receipt of information, ambulances can be sent to the wrong location. This is true. This happens.
Especially on our new address.
You know, the addresses actually help that.
The new people just saying
The new addresses, if you take the time to learn our new addresses, it is a mileage thing. It is, you can't go to the wrong. Hello.
Oh, really?
Yeah, I'll call you back in here in a couple hours when you can class. All right. But sometimes we get given the wrong information, just like I was saying. That happens. I will be mad at you guys if you guys go to the wrong area on good information. I understand that sometimes you guys get bad information. Okay, that's not your fault. But if you don't understand the addressing system and you go to the wrong place because they call in a name, let's say like here would be one that this would have to. They call in a name and you think you know where they live. You knew where they lived 20 years ago. They call in a name and they moved from the Raiden area to the Hammond area, and you went to the Raiden area because they called in a name and they gave you an address. I'll be upset with you. All right, because you just delay care to that patient because you don't know how to use the addressing system. You know how to use it; it's very easy. Just takes a couple minutes to learn how to use it. But anyway, dispatch often confirms receipt of transmission by repeating part of it back. Dispatch may end transmission with time for documentation according to 24-hour clock. Ours don't do that. If you don't say 10-4, you're on scene, 1824. I wish they did. They don't. One thing when I worked at Peak I liked is we had CAD, and so whenever we finished, every time we transmitted information, we were sent the time on scene. We got a page that of our on scene time. So whenever I was doing my chart, I just go through and look at it. Carry portable radio whenever you leave unit. Radios need proper care and maintenance. Guys, it's a full-time friggin' job trying to keep up with the radio. The batteries go bad on them. Frequencies, whoever programmed them gets the frequencies off like one number. You can still hear things, but not as well. You can't transmit. It's a nightmare. If you get a radio that you can transmit on and receive on, hold on to it. And then they'll change the frequencies on you sometimes. They'll get a new frequency. Oh, that's the old frequency. But you want to carry a portable radio whenever you leave the unit. One, so if you need help, you can call for help. I like the 800 megahertz system because you can push a little red button, and it's an emergency button, and they know right where you're at. They're able to send help your way. We don't have that out here, and this is somewhere that we need that. We need that emergency button. But also, you communicate with your partner, say that you need, holy cow, you need a spine board. Hey, grab a spine board. Anyway, radios need proper care and maintenance. If your radio craps out on you, you should let your supervisor know. If it's me, most likely I'll blame it on you, and it'll take me a month to fix it. So that's 10,000 other things going on. I try not to do that. So report must be given to destination hospital so it can prepare for arrival. This is something that my people are very bad about doing. If you don't believe me, ask Ellen. But then at times they get mad at us, and we had a whole 3 minutes with the patient from the time we were on scene to the time we're here because it's a block away. A lot of times they're good and they listen and they know, but sometimes you surprise them. And if at all possible, I would say, unless it's an extenuating circumstance and there's no way that you should at least alert them, hey, we're going to be there in 30 seconds. Sometimes,
They'll circle the block a few times.
We'll just go on that. Are you ready for it yet?
sometimes her staff's really bad about changing it over because they want to listen to a chase or something on the sheriff's station. And so when you try to call in because they're mad at you when you don't, throwing Ellen out here in the bus, you show up and they get angry with you, and you're like, I've been trying for 15 minutes to call you. My cell phone doesn't work.
See, a lot of times my cell phone works.
Then you walk over there and you say, well, the reason you didn't hear me is because you had it on the sheriff's show. Oh, yeah, we were listening to them do a chase. That's not on me anymore. That's on you. And so, it happens. And sometimes they do that too. They'll be concentrating on something, they'll turn the radio down and turn it back up. Moral of that story is don't get angry with them if they don't answer you. They might be busy in a room. I've gotten in the habit of, even when they don't answer me, I go ahead and give a report, because sometimes they're taking care of a patient and they can hear me. And they can hear me get the report. And that way when I show up and say, hey, I tried to get a hold of you, you didn't respond, I went ahead and gave a report to the radio or whatever. And sometimes they hear it, sometimes they don't. But cell phones work great. The problem with Roger Mills is you have to talk short. Hey, Charlotte, this is Robin in the ambulance. Can I talk to a nurse that's on? By the time we're turning the corner and pulling in, hey, I'm here. Bye. And so we're small. It's fast whenever you're in Cheyenne. But if you're coming from Raiden, Hammond, Crawford, there's not really good reason not to at least give them a heads up that you're coming. All right. So try to always give them a call. And the report, when this was written, said it's usually done by radio. Cell phone seems to be better. One, there's a better level of privacy. You're not given that information because people do have these channels on their scanner. Whoever gives them the frequency should be choked out. But anyway, they do have them. Structured to present only most important information. Speak clearly and slowly. On my pre and post run check sheet, on the back side, I actually have a radio communication template. You need to let them know your name and level, chief complaint, intervention, baseline vital signs, or your last set of vital signs, and your ETA. This is Rob on if I'm coming to the hospital. It's not here. This is Rob, paramedic aboard Roger Mills ambulance was currently at the facility with a 32-year-old male patient. Patient has a mid-femur dislocation to the mid-femur. We have a traction splint. Last set of vitals were 136 over 72, heart rate's 80, respiration's 18. Should have given medication and stuff back there. And we have an ETA at the facility of approximately 7 minutes. Now, sometimes you should start with your ETA and end with your ETA. I guess they think that's a very important piece of information whenever you read this. Has anybody read this chapter yet? Have they told you, did they tell you to start with the ETA? Yeah, so you're supposed to start with your ETA. I'm old school. I don't start with my ETA. I always end with it. Because after I get done giving the report, I look out the window to see where the heck I'm at. And so I can add better ETA. Or I'm like, yeah, we're at Four Corners, so I think it's about 15 minutes. Most of the time, the people receiving are cool, and they're just going to giggle if you give a silly ETA. But sometimes you get somebody that's kind of a jerk. What is it? Yeah, our ETA's down. This girl looks confused. I will promise you, giving a radio report will be one of the hardest things you get anxiety when you do it. You're like, here's a tip for that. Think out what you're going to say to the receiving hospital before you key out. All right. And you don't need to give a whole lot of information. You don't need to give meds and allergies and things like that. You're going to give that report as you walk in and talk to them. They're not going to write that down over the radio unless it's pertinent. Patient's allergic to bees and was stung by a bee. That's very pertinent that you tell them that allergy that they're stung by a bee. So, communication from ambulance can be radio or cell phone. Obvious. Medical radio reports, unit identified and level provider, estimated time of arrival, patient's age and sex, chief complaint, brief pertinent history of present illness, injury, and then major past illness. I disagree with this. Major past illnesses, unless it is pertinent to this call, aren't important. Patient does have a cardiac history. He is complaining of chest pain. That's pertinent. All right. If the patient has a mid-shaft femur fracture and they have they had stents placed 6 months ago, that is a major past illness. It's not pertinent to his mid-shaft femur fracture. So, it makes sense. Know that for this, but understand that you're not going to give patient has a history of CVA and cardiac issue whenever you're dealing with a broken wrist. Mental status, that's a good one to give. Baseline vital signs, pertinent findings and physical exams, emergency care given, response to medical care, and then contact medical direction if required, or if you have any questions. If you're going to get an order, let's say that you want to confirm a breathing treatment for this patient with a physician, or you want an order for it. You cannot take an order from a nurse, and you cannot take an order from a PA or nurse prac. It has to be from a physician, which I just learned this recently, which made the whole Diane thing. We have to call our medical director when I go in order. Makes all kinds of sense once you stop to think about it. We're operating underneath a physician's license. Mid-levels are operating under the approval of a physician. So they can't give orders for this physician. Nurses, and they can relay orders. So I could talk to Ellen. Hey, Ellen, can you ask Dr. Eubanks, I got this patient, let him know, blah, 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 and see if it's okay if I give him 4 Skittles. Okay. And then Ellen's going to go talk to Dr. Eubanks, come back, and she said, 10-4, Rob, Dr. Eubanks said they'll only give 3 Skittles. And I said, okay, 10-4, that's 3 Skittles. Repeat it back so she knows that I got it. Now, if I give 4 Skittles, I'm in trouble. I shouldn't have given 4 Skittles. And that's where that repeating back helps. If I just say 10-4, I'll give Skittles, and Ellen's like, all right. You get there and you're like, all right, so we gave the 4 Skittles. I was like, no, you're only supposed to get 3 Skittles. I'm in trouble. But if I say 10-4, that's 4 Skittles to the patient. I was like, no, correction. You need to get 3 Skittles. Okay, 3 Skittles. Now we're on the same page. So you always want to repeat back to the order. What's that? Yeah, okay. Echo it. There you go. So communication with medical direction, give information clearly and accurately. After receiving order or denial for medication or procedure, repeat back word for word. If order unclear, ask physician to repeat. If order seems inappropriate, question physician. Is that a whole bag of Skittles? You sure? Yes, I said to give a whole bag of Skittles. 10-4, I gave a whole bag of Skittles. What's that? And that's a good point. If the order is dangerous, a whole bag of Skittles is dangerous for the patient. Don't give a whole bag of Skittles. Take the physician being pissed off. As a matter of fact, I would do an incident report on it. I'd just write up an incident report. I called in for 4 Skittles. Physician ordered a full bag of Skittles. I felt that this was dangerous for the patient, and so I just didn't do anything. And I'd do an incident report on it. It needs to be brought to light. I had a physician one time, he was mad at me because I didn't intubate a patient, and she was a drug overdose. And she wasn't unconscious. He intubated her, and he threw a fit when he was in her mouth with the larynxoscope, in and out, and the eyes of the people standing around were this big, and the nurse was suctioning like, oh my gosh, and I mean his blood coming up. He did a lot of damage. I documented that. Or I did an incident report because last thing I needed was for him to say EMS did this to her. So I almost guarantee he broke teeth, tore up the back of her throat, and things like that. So document it. If it's something like that, you want to do an incident report. If that physician requested you do a full bag still, when you know good and well that that's dangerous. Okay. You are a patient advocate. Nurses have always known they're patient advocates. It's a new concept for us, but we're there to take care of the patient, and sometimes that means not fulfilling an order. So, the verbal report. Now, if it's a reasonable order, go ahead. Given upon arrival at destination, introduce patient by name, give complete and detailed report. I always feel so guilty when I take a patient and I forgot their name. I'm like, and so I'll just say, hey, this is 32, and I'll just start giving my radio report because I can't remember their name. If I remember their name, I will say, hey, this is Mrs. Kirk, and then I'll give the report. And but try to remember the name. I understand sometimes things just happen. I mean, you work your tail off. Last time you heard the name was briefly at the house, and you were working. It slipped your mind. Other things were more important, and it happens. So. Elements of verbal report. Chief complaint. Yes, I provide those for you guys. Please use them. Elements of verbal report. Chief complaint, history that was not given previously. So this is where I give the history. Now, I don't give it over the radio report. Assessment treatment given en route. Additional vital signs taken en route. Also tell them whether it helps or not. It's going to follow a lot the same as your radio report. It's just going to be more detailed. You're going to add things like their medical history, their allergies, medications. Interpersonal communication. Don't be a dick. All right? Right? So EMTs must communicate with others involved in patient care. First responders, advanced EMTs, paramedics, home health aides, and family. Speak candidly and respectfully. Collect information about the patient. Sometimes it's hard to speak, to talk respectfully, especially when you're dealing with somebody that said something so stupid. You're like, okay, whatever. But try to be respectful. Sometimes it keeps you from eating your freaking words. You're like, man, I'm glad I didn't say anything because now I got the whole picture. I see what they're saying now. Communication techniques learned by experience may be more difficult with those in crisis. Nurses are the worst. They come up to the back of your ambulance. I'm a nurse and blah, blah, blah. Great. Go to the hospital. This is my world. And like I said, that nurse-medic relationship has gotten much better. It's been a long time since I've had a nurse do that. And maybe it's because I'm not in a big city. Man, in Wichita, you'd have these nurses all the time trying to tell you what to do. That's great. Bye. Everyone can improve communication. I will admit, I get bad on critical patients. Whenever I don't feel like you're doing what you need to be doing. When you're standing there staring at me working, and I need stuff. I get kind of curt on it, and I really have tried to not do that. Sometimes it's hard. Whenever I need to intubate a patient or something, and don't have you haven't helped me get the stuff or whatever it is. I use comments like, yeah, I needed that 5 minutes type thing. So what's your hurry? But I've tried to not do that. And I try to remember that now I'm in a different system than a well-oiled system. Well-oiled system is me and you are partners, and we don't have to talk to each other very much on the call. Out here, you work with a different person at a time, and everybody runs the call a little differently. And like Ellen and I talked, you get with these lower levels at times, and they're looking at you for direction. Maybe it's something they would have done on a normal call, but now you're there, and they're looking for you for direction. And so it's something that I've had to try to regear my brain to is try to relax a little bit, not to be so hurt with my people, because then I feel bad. Like, sorry for saying that to you on scene, blah, 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 blah. Yeah, and you gotta apologize if you hurt the feelings. Yeah. So anyway, use eye contact. Show interest, comfort, and respect. And guys, this goes a long way. All right. If the person believes that you truly feel for them, that helps them out. Be aware of position and body language. Oh, if the person looks away, doesn't want to make eye contact, don't try to force eye contact. How about that?
In some cases, eye contact is considered rude.
You know you're going to be looking for that. So they're not going to be looking. They're going to be like that.
And then you just say, "Hey, I need to touch your people." And then you're like, "Dang, you don't even have any colored part of your eye. Your eye's black. What have you been doing?" No, nothing. Nothing. Yeah, right. Anyway.
There's a pretty big difference in the one that has been involved in them trying to hide the eye for me. Because I had practice when I was in Africa. It is disrespectful for one of those men where I was. So I just practice not doing it. Because here you're going to shake somebody's hand, you'll look them in the eye, and you're going to like that.
Yeah, form of disrespect.
Yeah, so you can, it's pretty easy to tell.
And we don't have a lot of that out here. Now, we might have some shy people.
Yeah, there you go.
But, we could do our job without forcing eye contact. Now, all you gotta do is say, okay, now I'm gonna assess your people. Most everybody wants to get behind that. If not, tell them to get off the room. Not really. Be aware of position and body language. I'm guilty, and people that are listening to us, I'm gonna stand up and cross my arms. I'm guilty of a lot of times just standing like this. It's nothing. I don't mean anything by it, but it's perceived as closed off, and I'm not really interested in what you have to say. Now, if I stand there like this, then I'm closed off. But so I try to, whenever I'm doing my assessment, I try to drop my arms, try to mentally do it and drop my arms. That way, I'm more open. So be aware of that. Face patient at eye levels with arms down. But sometimes I'm trying to get a point across, let's say a psych patient or a belligerent drunk, and I want to know I'm not messing around, and then I will play the tower over you as you're sitting on the third game, and because I want to do them, and I will close my communication off so that they know this isn't really open for discussion, and I'm not here to play with you. So make sure that you get that right. Make sure that you don't mix those signals. Communication with patients and others who are in crisis requires skill and tact. Sometimes, like this situation right here, your communication, or the person who's going to be the more agitated person is the dog than it is. What's that? Yeah, he's like, no. And sometimes they come out of left field with it. And all of a sudden you're like, whoa. Take 2 steps back. You're making me nervous. But anyway, and a lot of times just kindness brings that sometimes they're amped up because their loved one's sick. They're ready to be there to defend them, to make sure they're taken care of. And sometimes just simple act of kindness, and they see that you do care about their loved ones. They come down a few steps. Don't escalate the situation. Cops are really good about escalating the situation. You guys will see it where you'll get somebody who is a drunk and you're dealing with them, and the cops come over there and they rile them up for you. And you're like, thanks, buddy. That helps out a lot. And they're really good about doing that. They know what buttons to push because they like doing it. The cops are assholes. What's that? Yeah, your patient. If you ever get a cop that riles somebody up, I won't. No, you're right. You did this. You angered them. You're riding with them.
And they won't use handcuffs.
Well, you know what? You know why they won't? You know why they won't use handcuffs? Because if they use handcuffs, they have to stay there with that patient. So that's why they won't. If they use handcuffs, they handcuff your patient to your cot. They have to ride with you. So you'll see them a lot of times. They'll take the patient out of handcuffs, and they will not arrest them right there because they don't want to ride with you. They have to leave their patrol car. And now you get this person that maybe just beat the living tar out of somebody. But they're not. They're just going to. No. A lot of times you make them feel guilty. Like, man, seriously, you're going to submit this guy? You're just going to take handcuffs and submit this guy? I guess I'll go with it. Can I get somebody to come screw my patrol car? And they're real pissed off about it. But you know what? No, I'm not going with this guy without you. Some of them are really cool about it, though. Hey, you want to ride with me? Just no. Let's go. And so don't. I'm sitting there putting cops in a bad light, and if they're jerks, they can be. Some of them are really cool though, and work with you. Most of our sheriff's deputies are really cool guys out here. They're there to help you out. There's a few of them that might be kind of jerks. So be honest. Dishonesty ruins confidence and rapport. Another thing, not only that, don't tell somebody that they're going to be all right when you don't know if they're going to be all right. Oh my gosh, am I going to be okay? Your guts are hanging out. Yeah, you're going to be great. We're going to get through this. We're going to do everything we can to take care of it. That's all you got to say. You don't have to say, yeah, you're going to be fine. In a minute, you just won't even know about this. He's dead. Don't lie to them. What's that? Yeah. All bleeding stops eventually, sir. And yours is in about 3 minutes. So use patient's proper name. Sign of respect, especially with older patients. Listen, important to establish trust. I kind of said that already. Don't ask a question that you're not ready to listen to the answer to. If you got to continually ask questions over and over again, you're going to lose that trust with that patient really quick. Is proper name their last name? Is that what a proper name is? Yeah, Mr. Boyd, Mrs. Kirk. And then sometimes when, like I said, when you forget their name, this is a 36-year-old male patient.
When I walk up, if they're alert, I'll try to take a feel for a pulse, give them contact, and a call in the morning.
Yeah.
Once you got a pulse in, you know they're 86 hours.
Sabrina will tell you that there's no evidence that is true. The 80, 70, 60 that we've been taught forever and ever. She said, Rob, there's no evidence of that. Oh, I didn't know that. So Sabrina's a really sharp nurse. And even though I feel like she can learn a lot from the paramedics and on being in the helicopter and that side of it, I learned a lot from her on the nursing side, on patient care side. Sabrina's awesome. And one of the few nurses I've seen that has been able to embrace being an EMT RN, and that line is there, and she doesn't cross it. So, don't cross it. A lot of nurses, it's really hard to have the skill set like IVs and being able to do more advanced things, medications, and not being able to do that for a patient on the ambulance. And it's right there is an IV. I know for an IV, they need fluid. It's really hard for them not to do. So protect yourself or position yourself at or below patient's eye level to be less intimidating to aid communication. Make your statement of taking a pulse. Yes, human contact a lot of times de-escalates the situation greatly. But remember on the consent thing, you need to consent to touch that patient. If you touch that patient without consent, and implied consent is they get a check pulse. All it simply says, hey, I'm gonna check your pulse real quick, and they reach your hand over. You have consent. It's something to be aware of. I'm gonna be honest with you. Probably 90% of my patient contact, I never asked for consent. They called me to come help them. They're getting on my freaking cot. So now, if they say I don't want an IV, I'll say that as objection to consent to start an IV. But for the most part, I'm not going to say, can I take your pulse? Can I take your blood pressure? Can I feel your forehead? I think it's all, to me, it's all silly. They called me. Always be compassionate and respectful if the patient has a mental disability, have visual or hearing impairments, and has any language barriers. Guys, just because they can't see doesn't mean they can't hear. I am guilty of yelling at a blind person. All right, I'm guilty of that. Where are you hurting? I'm blind, not deaf. Oh yes, I forgot. My bad. Sorry. I'm guilty of this. Don't do it. It's hard not to though. We're human. Most of them will just laugh at you because they deal with it all the time. It's like, oh, okay, here's this again, and this asshole. So has a mental disability. Once again, kindness. Kindness goes a long ways in this field. This kindness goes a long ways in nursing and as a doctor and things like that. When you catch more flies with honey, then give me some good honey, than vinegar. I made my wife try your honey this morning. Yeah, I was like, I took a spoonful of it, and I'm like, here, try the honey. She said, oh, that's good. Anyway, and has any language barriers. I think as technology progresses, this is going to get easier and easier to deal with. True language barriers. Now, the ones that make me mad are the ones that won't answer any of your questions or anything, act like they don't understand English. And then a situation arises where they understand English real well. And you're like, oh, man, you're a punk. You understood what I was saying. Why didn't you acknowledge? And it makes them mad. It's usually whenever law enforcement gets involved and they don't want to go to jail. All of a sudden, they still understand the English real well. But with technology, we're getting a lot of apps and things where I could talk into it and just turn it and it repeats back in whatever language. So Croatian, we have a huge Croatian population out here. So I speak in English and it talks in Croatian. And then they could talk into it in Croatian in order to translate it into English. And the other side of that is if you have this large Croatian population, maybe you got to learn a little basic Croatian. Only Spanish word I know is dolor. Dolor. No. See. Oh, all right, we're good to go. Maybe having chest pain. So sometimes that's all it is. A lot of times I'll have an interpreter, somebody that speaks English. Which one of you guys speak English? It's usually the foreman. You'll see. What's that? Yeah, or the little kids. Little kids speak the English. But usually, if you get a crew and they're only speak, there is going to be a foreman that speaks English. Who is it? It's usually the cleanest guy, because he doesn't have to do anything. He's the interpreter, and so talk to him. Go to the cleanest guy first. And don't assume just because they're Hispanic that they don't speak English. I had a crew come in to do our cabinets, and I just knew that the Spanish guys did. They spoke very clear. I don't even think they had any. They must have lived in Oklahoma their whole life because they didn't. There was no accent, no Spanish accent to it. So I'm glad I didn't offend them by not trying to talk to them or something like that. But it crossed my mind. Oh, okay. Well, I'm gonna have to talk to that guy over there, the white guy. He spoke perfect English. Pediatric patients come down to their level. We've already said this, and be truthful. EMS used to carry stuffed animals. I threw all ours away because they're so freaking dirty. They'd be bad. We take it out. Ambulances are dirty. They get dust in them, so the little stuffed animals, no matter what you try, it's dirty. But if they have a little dolly with them, I'll allow them to take that little dolly. Like the guy's showing here, he's just showing what he's going to do to her on the dolly, which puts her at ease. Over here, I guarantee you, this is the caregiver that's sitting next to her. Caregivers help out tremendously. So I've had patients who've been in pretty bad car accidents that I didn't C-collar, I didn't spine board, because the second I tried to touch that kid, they were throwing a huge fit. To me, it was a bigger stress or I ran a bigger risk of exacerbating that injury by me trying to force these things on her than I did just having the kid lay in the mom's chest and getting used. And that's how I documented it. Anytime I tried to approach a kid, the kid became very upset and tried to get away from me, and so I didn't even approach the kid. And what's that? Yeah, there you go. Yeah. Pre-hospital care report. Written documentation of everything that happened during the call. Several forms. You have handwritten, laptop, tablet, pen-based computers, then drop or transfer report. So one thing that I provided the tools for, but we didn't take very well, was I added printers to all the ambulances. They could finish a report, print it off, and leave a copy at the hospital. It is required that we leave a copy of the report to the hospital. We are terrible at leaving a copy of the reports at the hospital. I wish that they would just set up an email account for receiving reports, because most all my reports I could finish up and I could shoot them an email with that report just like that. And I wish they would. But we use a laptop with an EPC, electronic patient care reporting. It's a combination of push button or laptop and handwritten. You could have the patient sign it and things like that. So it's kind of a combination of all of that. Patient care record documents findings and treatment, conveys picture of scene, entered into patient's permanent medical record. One thing that we were really bad at, and I think we're getting a little better, is telling the story. Whenever I handled QA, if I read your chart and I didn't know what happened on that call, or I couldn't come up with a picture, I made you add to it. Why? Well, because in 5 years, whenever so-and-so sees so-and-so, and you get called and you look at the report and it said, called to foot pain, transported to hospital. You're like, oh man, whereas if you tell that story, responded to a gunshot wound to the foot. The patient said that they were got into an altercation with their spouse. Spouse shot them in the foot, and you tell that whole story. You paint that picture. Now, whenever you go to court, you kind of have what's going on. And so, one thing you want to do is, whenever you write a report, is to draw that picture, paint that picture, tell that story. Our charting software has its limitations, especially since they changed on it. But I feel like it's one of the best. And a lot of it is just selecting things. You select a lot of different things, very little typing, if you will, until you get to setting your narrative. By the way, I don't know if you guys use it or not, but you should. Ours generates a narrative. You just select SOAP, because I only opened up one type of narrative, because I feel like all narratives should read the same. I feel like if we're going to use a charted method, we should use charted. If we're going to use SOAP, everybody should use SOAP. You should use it every time, so that you get in the habit of writing a report this way and you don't leave information out. And so we have it where it's select SOAP. Now you do have to go in there and type in things, because it'll say call to, and it's whatever you selected, sick person at, and you get the address. Well, after sick person, I start to tell the story. Call to sick person. patient complaining of respiratory distress, blah, blah, blah. And I tell the story, so I paint this picture. And that's important. So then whenever Ellen reads it, she gets that same picture. Legal document, it can be subpoenaed and used as evidence, may help patient win a case, may be used against you in a case of negligence. I'll tell you what, lawyers love sloppy charting. Love it. You're going to have a hard time defending yourself in a negligence case. Your biggest chance of this is going to be in your refusal. A lot of medics thought, oh man, I love refusals. Quick, easy chart. No, your refusal should be your most detailed chart. Arrived at scene with one shoe untied, spent 3 seconds time. Not quite that bad, but it should be your by far your most detailed chart, telling everything. Whenever you get done reading it, you should have a clear picture. Some elements, and I may go over this, that you need to have in your refusal is that needs to be an informed refusal. So they need to be informed that they have risks of dying if they don't go to the hospital by any means. Mine typically reads something into the effect of patient adamantly refusal upon 3, advise patient that their condition could become worse to include death. Advise patient to recontact EMS or seek medical evaluation if needed. Patient read and understand refusal form. Read, understood, and signed refusal form. Goes something to that effect. Did I leave a few things out? So, well, I'm just saying that's how I end it, because if you don't tell that it was an implied or a informed refusal, you didn't tell them. This is where lawyers love it. You didn't tell them they could recontact EMS, so they sat in their house, and now they have permanent facial droop from that stroke that you knew they were having, that you documented they had. But you didn't tell them they could recontact EMS, and boy, only if you would have done that, they would have recontacted EMS, and they'd be all better today. Bam, you're done. They got you. And so you need to make sure that you relay that as an informed refusal. Was it here? Oh, okay. I was like, man, tell me who the crew was, and I will. Because yeah. I'll tell you what this is, what he came across was laziness. See you later, Mitch. He came across a crew that just wanted to get back and eat their sandwich. They probably just got it warmed up. It's probably a hot panini of some sort. They just got it warmed up, and they get called to this T-bone accident. And this Yahoo's not even going to go with us. No patience. Bam, they're out of there. Get back there, hot panini, and eat it. That's pretty scary, because let's say that he, because it was a T-bone accident, he ruptured his spleen, and 45 minutes later, he died. Well, you get a report that he was evaluated by EMS. You're pretty pissed off. They didn't try to talk to him when he's going. So now you get a lawyer involved. Lawyer goes to the EMS service and says, we need your records on David, on this T-bone accident. And they're like, yeah, we determined he was a no patient. Oh, you just paid a lot of money. When you did, your malpractice insurance, the liability insurance that we carried did. And some other things could happen from that too. One, the medics were obviously negligent in his case. I mean, they were. Now,
They didn't check him at all,
wow.
other than just looking at him and asking him, are you okay?
So that's good. I mean, it's crazy. Yeah. And when I worked at Sedgwick County, we went through a phase where we go on these low impact accidents. Well, there is a no patient. I mean, there's not even a damage to the car. And they're not complaining anything. It was, oh, it's backing out and I accidentally hit them. Well, they call the cavalry to it, and before they could say, we don't need you, we're on scene. And so, anyway, we just go no patient. Well, you get the medics like what you guys ran into that they use that. They're like, well, you know, it's a lot less paperwork to say responded to car accident, no patient found on scene, clear without incident. A lot easier to write that chart than the big long chart of evaluation, and they know this. And so they get pretty dang lazy about it. And it's like, oh, you know, the accident was only 25 miles an hour, which is a lot of force, by the way. No patient. And so Sedgwick County took the stance that if your ambulance is called and you make it to the scene, there's not a such thing as no patient. You're getting a refusal on anybody and everybody involved. Medics find ways around this. Well, we have a 2-car accident, so we have 2 patients, even though we have 14 people in each car. Medics are lazy. They become lazy. Don't become lazy, because it can bite you in the butt. I've tried to kind of push that here that, guys, if it's any MOI at all, any damage to the vehicle, it's not a no patient, it's a refusal. And don't just get a refusal on one patient so you could satisfy me. You need to get a refusal on everybody involved. Because I'll tell you what, small enough community, I usually hear who all's involved. I'll catch you. You know, now, if it's a legitimate, high schoolers were pulling out and they just kind of came together and very minimal damage, yeah, there's no injuries there. There's no patient. Fine. But be careful with it. Yeah, that's pretty bad.
That's what I was thinking. Had I not been in this class right now, then we know, I mean, I would call that big.
Yeah, no, definitely. So, education and research. Functions of the pre-hospital care report. Education research, clinical research, statistics, continuing education, tracking EMT personal experience. The clinical research has made our job nightmarish. We went from a 1-page report where you had medics that wrote good charts and medics that wrote bad charts, but still it's just a 1-page report, to, oh my gosh, page after page after page, tab after tab after tab. You're charting for at least an hour on a short type call, maybe 30 minutes on a short call. Takes you longer to chart that call than it took you to run that call. But what it does is it gives them tools to do research, to see whether airbags are working. Are they deploying like they're supposed to? Is this Fiat Mini 500? Is it a safe car? And so they are able to do research like that. It's kind of the same thing with statistics. Continuing education. If my medics ever do a really good job on a call, I'll pull that chart. I'll cross everything out, and our whole monthly meeting will be geared towards that call. From talking about the elements that are involved in that call to the charting of that call and how they did a good job. Obviously, whenever you use it like that, you got to mark out patient information, but it can be used like that. And then tracking EMT's personal experience. I don't even know what the hell that's even talking about. It's kind of silly. Unless you are looking at number of calls EMTs run a year to make sure that they don't burn out. Quality improvement, routine call review, ensures compliance to standards, can reveal providers deserving special recognition, can reveal opportunities for improvement. And with our QA process, it helped me realize that we had no clue what our protocols were. And so we use that. And I like Vicky. I think she does a good job, but at the same time, I don't think she's worried about hurting people's feelings. Oh no, they didn't do this. I don't. So what she does is she asks me, and I'm sure I only get the worst of them, and I tell her what to say. But it's not punitive. You're not in trouble. Learn from it. You need to do a better job, or you need to consider this next time. Okay. Data elements, National Highway Traffic Safety Administration. More than 400 elements, minimum data set available nationwide, blah, blah, blah. Run data, agency name, date, time, call numbers, unit personnel, level of certification, other information mandated by service. Use official time given by dispatch, so all times in report match. I disagree with this out here. The reason I disagree with this is because we also have a jailer dispatcher who estimates time sometimes. please keep your own time. Our monitors are set from GPS time. Use your phone. It's a global position system time, or a time given to you by satellite. It's much more accurate than their, oh, I got back from putting them back in their cell about 1642, and then you called about 1643. Okay, cool. Or you know what? I was taking a bathroom break. I didn't take that time. What? And my thing, and I have a yes for the testing. Do this. My problem with it is that you keep a consistent set of times. So if you're going to use your monitor, which documents the time as it timestamps it and puts it into your chart for you. So if we're using that GPS time, all of our time should be up with GPS. So it's kind of in sync with each other, right? Not whatever they have there. And so that's another reason that I like keeping my own time. Here's your patient information. Know these elements that are in a chart. Information gathered during the call, general impression of patient. Narrative is a summary of the call, patient's prior age, past medical history, blah, 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 transport information. I've been talking about this stuff all morning, right? Narrative sections, objective information, observable, measurable, and verifiable. Unless you're going to quote what the patient says, like patient stated. I wouldn't paraphrase. I wouldn't say patient stated in parentheses, because maybe they didn't say it exactly like that and you just messed it up. I just say patient stated they have a full set. Subjective information subject to interpretation or opinion, often reported by patient. There you go. Narrative sections, chief complaint, primary complaint as stated by patient, best recorded as a direct quote. Yeah, okay. I don't really like doing direct quotes because I'm sure enough that. Pertinent negative, important negative findings. One thing that I don't think we do well enough here is a pertinent negatives. Patient denied, shortness of breath, vomiting, whatever it is. It's all important to that chest pain call, right? And so make sure you document the pertinent negatives. How close are we doing on this? A lot still? Oh man, we're halfway through. We're not going to get through 16, so we'll have to do 16 on Monday. Tuesday, whatever. Same thing.
We're not gonna get through 15. We're on 16.
No, 16. I said we won't get through 16. I'm going to take a quick break because I got to go to the bathroom, and then we'll try to get through 15 a day. I mean, we have we're a little over halfway, and so we'll get close. No. It's on YouTube. You can fast forward to it this time. No, please go. I'm not saying I won't be there. I just won't be there.
Thanks. Hey, if you're texting me, I called in a prescription order, so later we don't make it by noon, you know, to like overtime. I need it today.
Okay.
I don't know if you know if I'm down in your class or not.
Yeah, I think so.
Yeah, yeah. Oh, my goodness.
All right. Let's continue on and try to get close to finishing this in. I didn't realize this was 70 slides for the day. So, narrative section, void radio. What? Narrative section, avoid radio codes and non-standard abbreviations. Talked about this already. Abbreviations on their way out. I just wouldn't even use them. Write legibly and use correct spelling. Information must be read easily and accurately. PCR is a reflection of your care. If you do poor PCR, it's assumed you do poor care. Use appropriate medical terminology. If it's not written down, you did not do it. All right? You'll hear that over and over and over again. It's the truth. So, moving on. Special documentation issues. Confidentiality, covered by the Health Insurance Portability and Accountability Act, accountability and security. This is something that I struggle with here, having people, you don't have to answer, well, how is so-and-so? Sorry, I can't tell you that if that's your standard answer. Come up with your standard answer, but don't talk about patient care. Okay? With the EPCRs or patient care reports, don't share them with people that aren't directly related in the care of the patient. If an attorney calls you and says, I need a chart on so-and-so, yeah, you might need it, but until we get the signed off form or you subpoena it, we can't give it to you. I get into this with the OSBI and even FBI at times. They want a chart. In our sheriff's department, they want a chart, and I tell them you need to just get me a subpoena, just get a court order to get it. Well, if we have to go that route, I'm not trying to be a dick here, but you should know that if you go through back channels to get this report, it's going to get thrown out, And I don't know that that's exactly what they do, but I don't feel like I could just give them, and they want to throw a statute out there why they could do it. I'm like, whatever, and they want it because they want it. Some of the guys are pretty cool. They're like, that's what I need to do. I'll go ahead and do it just so the law is such and such, and I don't have to get that. I was like, okay, but it make me feel better, and it helped the administration here at the hospital feel better if you went ahead and went through that channel. But anyway, patient refusals, a high liability. Document all details in their refusal of care form. Falsification, covering up errors, recording something you forgot to do. So on that, guys, Ellen said it earlier today that she taught her daughter that if you did something wrong, don't lie about it. Fess up to it. The repercussions are going to be a lot less than if I find out that it's a lie. That's the truth here too. If you accidentally gave 2 times the amount of fentanyl that you should have, you know what? We need to do some training and stuff on fentanyl. It's probably going to be reported to the state. We'll go through an investigation. But you're probably going to be fine at the end of the day. If it comes back, the patient dies because you gave him too much fentanyl, aspirin or whatever it is. At the end of the day, they die, and they come back and they look at your chart, and the chart says one thing, and they find another thing. They interview your partner. Say, well, he did give a full handful of that aspirin. You know, they find out different. It's going to be a completely different story. Now it's probably you're probably going to lose your ability to work as an EMT paramedic or whatever. You know, if you forgot to put on a C collar, don't chart that you put on a C collar. Give you guys a tip on how to do things like that. Try to think of something that happened in the call. Why your justification? What was your justification for not putting on that C collar? If you have a good justification, put that. Don't put the C collar on because you didn't. If you have a justification for not doing it, right or wrong, you know, put that justification in there. Go through the QA/QI process. Well, you know, hey, did you consider doing it, you know, this way or whatever it is? You'll go through a QA process. But don't put that you put something on that you didn't. Correction of errors, mistakes, and documentation in addition. How you do this is through an addendum. Don't go back in, and I think we got to where we're locking our chart. Don't go back in and add to that chart later. All right. Once you submit it for QA/QI process and it's gone to state, you can't go back and add to that chart. Oh man, I forgot that we put a splint on that ankle. Even something as simple as that, you have to do an addendum. It came to my attention that I forgot to put splint at an ankle, and you do an addendum. It attaches right to the chart as an addendum. It's easy to do, and that's the best way of doing things. You actually get and properly document. So, response to a call for an unconscious male. Upon arrival, the patient is awake, alert, and walking away. He states he was just sleeping and does not need or warrant treatment or transport. Is this the patient? Can be, right? Is a complete assessment and physical exam needed? How will you document this call? Should you obtain a formal patient refusal? This is one of those that wasn't called by bystanders. Was it called by somebody driving by? If you get there and the guy's like, you show up, let's say that he is walking away and refuses. He probably should have been but are you going to put yourself at risk to go get this information? If they slightly agitated. I'm thinking of the homeless downtown Wichita, Kansas, the homeless population. Most of them are schizophrenic. Do you really want to go push his button? No, if you're really concerned about it, get law enforcement involved. Technically, he should be a patient. You should get a refusal on him. But let's say that I have had this one. Family said that they couldn't arouse him. You get there, you go and wake him up, and they are fine. Nothing, absolute nothing. And she's like, I just stayed up a little later than usual last night. And the thing's like, well, yeah, whenever she's tired, it is harder to arouse her. You can do a full chart on that. I don't, but you know, if something doesn't sit right with you, yes. But there's all kinds of scores. You gotta judge each one for yourself. The person, you know, you get there like they're sleeping in a park, you know, just here in the park, they fall asleep, you know, or it happens. Somebody drives by and sees them and says, "Oh my gosh, there's a dead person." Call us in. We get there. By the time we get there, they're sitting there, and they're like, "Oh, no, it was a nice day out. I was laying in the sun. I fell asleep." They're alert and oriented. They're answering all the questions. Story jives. No, he's not a patient. So, multi-casualty incidents, logistical problems for EMS and patient care and evaluation by several providers at different times and locations. My people are terrible at this. To the point that I've made a sheet that, you know what, get somebody that's going to stay there on scene and get refusals from all your people. All right. They're hard. You get a critical patient, 3 serious patients, and then you have 4 more patients that aren't even hurt. But you know what? They're involved in this wreck. They are patients. You do need to get a refusal on. And you're trying to get these other ones that need transported on their way. If possible, get somebody that's there. Additionally, in EMT, a lot of times you have extra help to get all those refusals. Those are complicated, by the way, getting all the refusals on the scene. Sometimes you just have to get names, get the demographic information, the name, date of birth, that kind of stuff. Get a baseline set of vitals, really quickly inform them, have them sign your tablet. We used to, and I haven't seen on this one, we had a add patient. So you put in the call information, and then you add a patient, and so you start attaching all these patients to the same call information. It's easy. Get their information, you jot it down real quick, and then just have them sign. Next one, have them sign. The new Elite Pro or whatever it is that we're using now, the same company, they don't have that add patient yet. So you have to start a new chart on each one. So it makes it problematic. For logistical nightmare, we have a paper form to sign. We scan it and attach it to a chart right now. So special situation reports, exposure to infectious disease. I actually rely on Ellen for this a lot. If one of my people are exposed, it's one of the big advantages of being attached to the hospital is I'm like, Ellen has an exposure plan, and that's the exposure plan that we go through. We go visit with Ellen. Injury to yourself or another EMT. Once again, Ellen has that. Ellen has a lot. I use Ellen a lot. She has a COOP plan. Yeah, hey, you know what? You have one. I'm using it. Anytime that I don't have an answer for the inspection, I'm like, oh, the hospital has one. They go, okay. So they go all, well, we need to see that. Ellen, I need. Hazardous or unsafe scenes, referrals to social service agencies, mandatory reports for child or elderly abuse. Oklahoma, this is a mandatory reporting, only mandatory reporting. There's reports for child or elderly abuse. Hey, chapter review. We're going to get through this, right? So when calling in patient information includes these elements: unit identified and level of provider, estimated time of arrival, patient's age and sex, chief complaint, brief presentation, and history of present illness. Major pass, please, gosh. Mental status, baseline vital signs, pertinent findings of physical exam, emergency medical care given, response to emergency medical care. When calling in patient information, include these elements: contacts made with medical direction if required, or if you have questions. That gets important as you go through your levels. You become a paramedic, and you gave a medication that required a physician order, and you didn't put in that contact, most likely you're going to hear from somebody on that issue. When completing the pre-hospital care report or PCR, include following: patient's name, address, date of birth, age, sex, location of incident. Do they have that in there? Yep, location where patient's found. So, billing and insurance information in many jurisdictions. Nature of the call, mechanism of injury, location where the patient found. The billing and insurance information is hard for us sometimes. You get an unresponsive patient on the side of the highway with no identification information. We don't have any. You're dealing with a critical patient, it's a high acuity patient, and you're spending all your time taking care of them. Is billing information really at the top of my list? No. Yeah.
I mean, you know, and then it's like that.
Yeah, and that's the same with us. We take care of the patient, and then we'll worry about billing information. Treatment administered before arrival of the EMT by bystanders, emergency medical responders, or others. This also could deal with if you're going to do a transfer, document what the hospital staff has already done. Signs and symptoms, baseline and subsequent vital signs. Sometimes, like, you get a mom that gives a child Tylenol or something like that, or the patient is having chest pain and they just go ahead and take their aspirin. Just document it. That's why you didn't give it, and so you need to document that it was given before your arrival. Changes in condition throughout the call. A PCR may be illegal maybe it is a legal document in a court. Oh, maybe a legal document in a court proceeding. Data from PCRs may help determine future treatments, trends, research, or quality improvement. Your report should paint a picture of your patient and their condition, accurately describing your contact with the patient throughout the call. If I can't see your painting when you're done, you're going to be fixing your chart. Emergency medical communication comes in many forms and is essential to team-based patient care. The medical radio report is structured to present pertinent facts about the patient without providing more detail than necessary. It's so they could prepare. So Ellen could get the doctor down there if need be, or she could be ready with more hands on deck whenever we roll through the doors if they need it, or get sometimes radiology get Phil on his way down here because he went home for the night. And so the information gets the cavalry coming. So a proper verbal report will include the chief complaint, any history that was not given previously, additional treatment given, and additional vital signs taken en route. Interpersonal communication is often challenging in EMS. Adopting best practices can improve communication capabilities significantly. I'm going to say be nice. Always be nice and courteous, even when you don't completely agree. Confidentiality, patient refusals, and falsification of records are all important legal concepts that you must consider when documenting a call. How can you improve your interpersonal communication with patients and team members? Well, obviously, you need to have a strong base of knowledge, right? But be courteous and respectful. And that will go a long way. If you're courteous and respectful, even when you disagree with somebody, a disagreement goes a lot better than if you get in their face about it. And I've seen fist fights between firefighters and EMS personnel on scene because we are terrible at interpersonal communication. What is objective and subjective information in the narrative portion of the PCR? Objective is your facts and things like that, the object of it, right? Subjective is, I was just confused, but subjective is kind of what they're telling you, what the subject tells you has happened. Organize this random information and present a radio report to the hospital. I'm not going to do that to you guys. We may practice on some radio reports though a little bit later. I'm not going to do it today. We have 9 minutes and I'm out of here. Organize. We're done.
We're going to 9.
9 minutes isn't enough time.
On that, on your radio, I hit
Oh, does it? Okay, how do you do one? So all my peeps out there in Radio Land, I'm done with you guys today. Any questions from anyone? No? All right. Next week, I'll try to send out an email Monday, kind of what we're going to do, because we're going to have to kind of change our game plan just a little bit since we didn't get through 16. We're still on track, so it's not like we're behind at all. And so we'll definitely be going over 16 on Tuesday. But I'll try to get an email out just to, what the game plan is. Remember, we don't have lab for 2 weeks now. So it's 3 weeks before we have another Saturday. Not lab. It's 3 weeks before we have another Saturday class. So, yay. So, nobody has any questions. I'm done. Talk to you guys later.